Welcome, everybody, to the first inaugural Four Corners Plus Educational Day. Thank you for joining us. My name is Dillon Warr. I will be your moderator and host for today's event. I am currently a faculty member with the Creighton of Phoenix, Arizona Emergency Medicine Program, historically COPA, and part of AAEM's Leadership Academy. I do want to give out a shout out to AAEM, who has graciously supported and encouraged this endeavor, as well as all the speakers who have graciously volunteered their time to make this day special. If you haven't figured it out at this point by the graphical representations, this endeavor brings together the emergency physicians of the Four Corners, Arizona, Colorado, New Mexico, Utah, plus Nevada, hence the plus. Together we are 4CP. Feel free to email with better names for this collective, but this is what you get today, 4CP. So this educational day is unique in that we are going to be hearing from speakers from each and all of the 11 emergency medicine programs in our region. They are going to deliver rapid fire clinical information that will hopefully and undoubtedly enrich the practice of EM physicians of all levels. Buckle up, folks. This is going to be a wonderful ride. I would be remiss to not mention that this educational day is the first major initiative of our proposed regional AAEM chapter that is currently in development. This is our blast-off event, and we hope this will carry us towards chapter formation. And I do want to plug this chapter ever briefly here, just because I have you all captive. So we aim to educate and raise the bar for patient-centered emergency care. We want to advocate so emergency physicians speak with one clear voice. We're hoping to defend physician rights and push back against corporate control of our specialty. We are going to hopefully unite students, residents, and attendings into a connected regional community, and we want to elevate emergency medicine by supporting physicians at every stage of their careers. And if this is something that speaks to you and you want to see an AAEM chapter stood up here in the Four Corners region, please just scan this QR code, fill out this form, get your name on the list. We need about 100 people to get off the ground. So if you can, take a second, throw your name down. And if you're up for a bigger role, interested in becoming a board member or resident rep, feel free to shoot me an email or note it here on this QR form. All right, enough advertising. Let's dive into this. This is our roadmap today. We're going to have 11 15-minute rapid fire talks. There will be several breaks. Don't worry. We'll then have a keynote speaker. The AAEM RSA president was going to plug this amazing resident-run organization. We are then going to vote on a variety of speaker awards who will get some award prizes. And then we have a resident raffle at the end for the residents who remain on the call. So some exciting stuff at the end of our day. Stick around. Brief shout out to our special guests. We have Dr. Katie Wesneski, who's president of AAEM RSA. She's going to be joining us to talk about this organization and help deliver the resident raffle. And then we have Dr. Vicki Norton, who's the current president-elect of AAEM National. She's going to be talking on the state of emergency medicine as our keynote speaker. So stay tuned for their presentations after our lightning talks. If you want a detailed look at the lineup and schedule for today, there was an email sent out to all of the registrants with the detailed program schedule and speaker bios. You can also find it on the AAEM website. We're going to keep the program moving. Introductions are going to be really brief. So if you want to know about all of these amazing speakers, check out their bios. You can quickly here look at these QR codes for your convenience. So during today's session, if you have questions, please send them our way during presentations. If we have time, we'll have a brief Q&A after each talk. However, for everybody's sake, we are going to do our best to keep a strict schedule. Speakers are encouraged to share their emails if they would like to, if you want people to email you with a specific question afterwards. All right, it is time to get the party started. As a reminder for faculty attendees, this is worth 3.5 CMEs, and our first break is already in sight, 45 minutes away. Okay, but let us move on to our first speaker. It's going to be Dr. Simone Miller. She is an assistant professor of emergency medicine and associate program director with the University of New Mexico Emergency Medicine Program. She's going to be presenting Grace in the Transfer, Building Respect and Optimizing Care Across the Rural Academic Divide. Dr. Miller, after you.
All right, thank you so much. Let me go ahead and share my screen here, and then we'll try to put this on presenter mode. How does this look to everyone here?
Looks awesome.
Good. Okay, cool. As Dillon said, I am going to be talking today about how we can build a respect and ideally optimize patient care across the rural academic divide, specifically in regard to ED to ED transfers. And although I have previously worked in a rural ED in our region, I primarily now work in the academic capacity, as you can see here. And so I am going to be primarily talking today from the perspective of those of us working in academic transfer centers and receiving these patients when they come to us in the ED. So with that said, my objectives for today are pretty straightforward. Ideally, I'm going to try to describe some of the unique challenges faced by rural EM providers in our region. And ideally, by the end of this, I'd like you guys to be able to demonstrate some strategies that we can use to approach transfers with more respect and curiosity, thereby fostering collaboration and hopefully improving patient care along the emergency medicine continuum. With that said, let's start right away with point number one. And I think that for anyone here, unless you've been living or practicing under the proverbial rock, it is no surprise that rural areas have been hit pretty hard in recent years by the current economic and political climate in regards to healthcare in this country. And that even before some of the most recent proposed Medicaid changes, many rural hospitals in our region were facing closure. And when this happens, it's a huge blow to these communities and also puts incredible strain on the remaining institutions, which need to try to pick up the slack and find ways to care for these patients. Furthermore, for hospitals that do remain open and are still functioning in these regions, we know that physician shortages are a big problem. And this is true across pretty much all specialties, not just emergency medicine, but recent data from the past year shows that unfortunately this trend is probably getting worse right now and not better. So what does that look like if you're one of the people who are actually on the ground working in these areas? I think this adds a tremendous strain to these providers' day-to-day jobs, in addition to many of the challenges that they're already facing on shift in a given day. And so what do some of those things look like? I think anyone who works in a rural environment probably gets comfortable pretty quickly with working under varying degrees of resource limitation, but it's not uncommon, I think, to face unexpected shortages of resources that you thought you did have. For example, there are several institutions in rural New Mexico which do have CT imaging capability, but it's not uncommon for them on any given day to suddenly not have that available, maybe because one of the two radiology technicians who serve that community were not available. For teams that work in rural EDs, it can be very hard to practice clinical algorithms and protocols that rely on repetition because teams may be smaller and constantly changing, and things that would constitute high acuity, low occurrence or halo procedures, even for us in academic centers, maybe even lower occurrence in some rural settings, but that makes them inevitably higher stakes when they do ultimately show up at the door. I think for anyone here who's worked in a rural environment, I am absolutely preaching to the choir when I say that one of the most challenging things can be simply finding a place to accept, with an open bed, to accept your patient when you do have someone who has clinical needs that outstrip the capabilities of your environment. At the rural ED that I used to work at, we had a transfer form that had about the 30 or so closest transferring institutions. I mean, it was not uncommon when trying to send someone out that you would make it all the way to the end of the second page and have received 30 no's by phone. And that can be like an incredibly defeating feeling when you're in the moment on shift, trying to do the best you can to care for that patient. And finally, even when you do get that accepting institution, you have a crew to safely transfer that patient, there are inevitable things outside of our control, things like weather and natural phenomena, especially in the Mountain West, that can make that transfer at least temporarily impossible, even when you've done the absolute best resuscitation that you can possibly do. But interestingly, I would argue that one of the most unfortunate and uncomfortable challenges faced by providers who work in these environments is not any one of these things that we've talked about so far, but is actually stigma from the rest of the medical community and other providers. And I spent a long time looking for other resources to better elucidate and back up this phenomena that I really wanted to describe today. And it turns out that there's not a lot of published information out there about this. But for anyone who's at all curious about this area, I would encourage you to check out this very brief 2-page opinion piece that was published back in 2014 by ACEP through the Journal of Rural Emergency Medicine and written by Dr. Edwin Leap. And he just so beautifully and eloquently describes this phenomena. And he says the following: the stigma is this: if you practice in a small rural hospital, you must be less than competent, because if you were competent, you practice in a large urban teaching or trauma center. And I want everyone to pause for a second and just consider this. Like, A, have you ever been on the receiving end of this? Or B, have you ever heard people talking in a way which exemplifies this? Or have you yourself ever found yourself thinking or speaking subconsciously or consciously in a way that exemplifies this? And I'll say personally for myself, like, even having worked in these environments and having incredible friends and colleagues who work here every single day, like, there are times in my weaker moments on my stressful shifts where, like, I find myself having thoughts or assumptions which trend in this direction, and I'm not proud of that, but I think that it speaks to just how, like, deeply ingrained and rampant this is, even among our medical communities. And he goes on to say, and I'm sorry if I missed some words here because my speaker images are slightly cutting off some of the text on my slide, but he goes on to describe how during residency, we love to hear the thump thump of those helicopter blades coming into our trauma bays with things that other facilities just couldn't handle. Feels good sometimes, doesn't it? But we forget too easily how comforting it is to hear those same rotors as they fly away from small hospitals with limited resources who did their best with very little. And I was curious, is there any more quantifiable evidence out there to try to support this phenomenon that he's describing that a lot of us have seen? And obviously, finding tangible data about something as nebulous as provider to provider stigma is really hard, and there's not much out there. But what I can offer is this. When we've surveyed rural and academic EM providers and providers in other specialties, not surprisingly, we have different priorities from one another. We tend to place value on different specialties and services in different ways. And we have different expectations about what services should or should not be available, what things should or should not be performed, and what impact this has on potential transfers. And although provider to provider communication challenges are, like, so common in this job, right? Think about any shift you have talking to a consultant. That's not an uncommon phenomena in and of itself. But when this happens between rural and academic providers, it tends to disproportionately harm rural health systems. And this is problematic for a variety of reasons. We know that stigma like this certainly has the propensity to negatively impact physician recruitment and retention in areas that we already identified may be struggling in this realm. And ultimately, that's going to negatively impact patient care, which presumably is why we're all here doing this job. With that said, what can we do better tomorrow before our next shift to try to combat this stigma and be a better steward of emergency medicine among our communities? And one of the first things I would recommend is get to know some of the rural facilities near you. I happen to be particularly passionate about this area, so I have tried to make it a point to go and visit several of these institutions, meet people on the ground. I've done teaching and CME work, even in areas where I don't have any, like, clinical association with, but that's extreme, and that's not necessary just to get to know some of these places a little bit better. I would say for any of the residents on here, if it's like the third time in a month that you've seen a transfer patient from somewhere that you can't even confidently identify on a map, look it up, take 30 seconds, get to know that facility a little bit better. How big are they? What services do they or don't they have? That will give you, like, a much better sense of context for where that patient's coming from and what their journey has looked like before they arrived at your doorstep. And number two, if you can, make a real effort to get to know some of the providers who work in rural facilities in your region and in your state. And I'll give an example of one way you can do this at the end, but just to give you some context for who some of these people are in rural New Mexico, I would describe this. They are an incredibly diverse and heterogeneous group. They definitely do not fit into any one box. Many of them have years, if not decades, of clinical experience, oftentimes much more so hands-on at the bedside that many of us academic attendings may be getting in our current day-to-day work. They include the former chief residents of competitive four-year EM programs. I know folks who are fellowship trained, who are widely published and nationally known, some of whom have started and lead national academic conferences, who maybe also work per diem shifts in academics. You probably see some of them on shift in your own emergency departments, and so much more. So having all of this in the back of my mind, how do we translate this to doing a better job with the patient in front of us on our next shift? And these first few things here, right, these are easy. These are layups. These are the things which I'm sure all of you guys are doing automatically every single day simply by virtue of being good ER doctors. When a patient arrives at your doorstep, you are doing a good job stabilizing and resuscitating them as needed. You are being quick to reassess things like pain control and sedation needs after a long transfer. You are not forgetting to order things like scheduled antibiotics or timed repeat imaging studies when necessary. When you're quick to look for that transfer paperwork packet to get a better sense of what happened to your patient before they arrived at your doorstep. If you're not already doing so, I would encourage you to try to always read the provider MDM in there, even if you feel like you got an excellent warm handoff from EMS. I find that even if I think I understand the story, it can be so helpful just to read what another doctor was worried about, what they were seeing, what they were concerned about before that patient got to me in terms of continuity of care. But again, this is the low-hanging fruit. If you take nothing else away from this talk, I would encourage you to focus on the next three things that I would advocate all of us try to do or at least think about every single time we receive one of these patients at our own doorstep. And these are as follows. First and foremost, just try to mentally put yourself in that provider's shoes for a second. What might it have felt like to have been alone, single coverage, in the middle of the night, potentially with multiple critically ill patients in a snowstorm, and trying to do the best job you can caring for that patient and getting them to definitive care. Number two, regardless of what condition that patient arrived in, always make an effort to speak professionally and with dignity about other providers and institutions, especially when you're in front of patients and their families. I think that the tone we set and the way we talk about other individuals in healthcare really can have a big impact on the way patients view their own communities and the trust they have in the healthcare system in general. And I think the same thing goes for the way we speak in front of other learners, right? Students or residents who may be relatively early in their careers are undifferentiated in their medical journeys and the future decisions they're going to make as far as their own career pathways. And then finally, don't hesitate to pick up the phone and call and talk to someone in person when you have any questions whatsoever. And I know there's probably some people out there who are like, all right, Dr. Miller, like the last time I tried to reach a SNF that's 2 miles down the road at 4 p.m. on a Tuesday, I couldn't even find someone who knew the patient. How am I going to reach someone 100 miles away at 2 a.m? But I would just say from experience, like the process is almost always successful for me. And I am almost always connected with someone who is so thrilled that I called and so happy to give me more information. Just on shift a couple weeks ago, I had a patient that had a really complex situation that had happened that I needed some more information. And not only was I able to reach someone very quickly, they like immediately connected me with the actual provider who had been on last night caring for that patient who was now at home post-call, but who had just woken up, who it turns out was someone that I knew, who like immediately called me back on my cell phone and was like so thrilled to talk to me and fill in all the information that I needed. And it was like a very mutually beneficial conversation and took maybe 6 extra minutes of my time as an attending. And so I would say, do not be afraid to pick up the phone and try to do that if you think it might be at all helpful. And finally, I would say this, right? For anyone out there who's like, okay, this is all well and good, but like I have definitely had instances in which I feel like I received someone and the standard of care was not met, or mistakes were made in terms of therapy or diagnostics. There was room for improvement. That's fine. I believe you. I have been there. This career field is imperfect and things happen. But I would advocate that we really strongly resist the urge to make sweeping generalizations, especially negative generalizations based on single cases or interactions, right? If you find yourself trending towards language such as, every time we receive a patient from X institution, it's always a total train wreck, or man, can you believe that Dr. So-and-so did X, Y, and Z? They must not have any idea what they're doing and must be completely incompetent. I think I would encourage everyone to judge others through the same lens that you would like to be judged on your hardest night or worst shift, and to keep that in mind when you're thinking about the people who work in your communities. And finally, if you're really motivated, I encourage any of you to check out the possibility of working in these environments. We know that these places are oftentimes in need of high quality, well-trained emergency medicine providers like yourselves. whether you're a resident considering a future career path or an attending considering work on the side to stretch your legs clinically, these can be incredible places to work. But if that feels like too much, that is totally understandable. There are other ways that you can broaden your perspective in this realm. And one of the ones I would advocate for is the Emergency Medicine Rural and Indigenous Communities Conference. And I have absolutely no conflict of interest here, nothing to disclose. I'm not in any way involved in the leadership of this, the production of it. I'm not a speaker for it. I've just attended before. And I think it's a really fascinating and unique academic conference that's really unlike a lot of other things out there, and will introduce you to some people working on the ground and facing some of these issues in rural environments that you may not have previously thought about. So just something to put on your radar if you're interested in meeting more folks who work in these environments. So in closing, I would say that caring for patients on either end of the rural or academic spectrum can be a fascinating, humbling, and challenging experience, and is almost always, at least for me, an immense privilege. Remember that we are on the same team, and that you should always be striving to be good colleagues and neighbors in emergency medicine. In doing so, small steps, honestly, and small changes in communication and behavior can go a really long way. That is all that I have for today. I really appreciate the opportunity to start this morning off and to speak today. And I'm not sure how much time I left for questions, but hopefully I am mostly otherwise on time here.
Thank you, Dr. Miller, for giving us some valuable insight into kind of the other part of emergency medicine that we don't think often about, and giving us that perspective. So we appreciate it. But we are going to keep on moving here. If anybody has any questions for Dr. Miller, feel free to send her an email. We are going to move forward with our program. Up next is going to be Dr. Matthew Kamer, Director of Scholarly Activity with Abrazo Emergency Medicine. His talk is Why the Pharmacokinetics Actually Matter. Alcohol withdrawal.
Hello. Thanks for having me. Did everybody see my screen all right? Perfect. We're going to talk today about alcohol withdrawal, especially severe alcohol withdrawal with a heavy focus on the pharmacology. Unfortunately, I don't have any disclosures. So we'll start off with a case to set the stage a little bit. We have a middle-aged male presenting with tremors, anxiety, nausea, vomiting. He ran out of his so-called pill people milk 24 hours ago or so. And like every ER patient presenting with nausea and vomiting, you can see him trying to drink from a water bottle when you walk in the room. Clearly, there's some significant hand tremors. Since I already spoiled the diagnosis with the title slide, we'll talk about our initial treatment options for this guy. And let's say you had a quick second to review the chart, and you see he's been intubated in the ICU before because of severe alcohol withdrawal. This is the real deal. So these are some of our initial options. We've got lorazepam, diazepam, phenobarbital, and then this tiny little vial of midazolam. Just a brief note on midazolam, definitely not ideal by any means to use in alcohol withdrawal, but because of the short half-life, but sometimes you may need to give a dose in a severely agitated patient without IV access yet. Then I would say it's okay to give an IM dose to facilitate the treatment, but otherwise, not really a good option for alcohol withdrawal, but worth mentioning. Our other ones here, we're giving them all hopefully IV, of course. We can do 2 to 4 milligrams of lorazepam, 10 to 20 milligrams of diazepam, or 130 to 260 milligrams of phenobarbital up front. And you can see that corresponds nicely with the common vial sizes that we have. We'll talk more about the phenobarb dosing later, but the vial comes in 130 milligrams, so sometimes giving 1 or 2 of these up front is a little bit more feasible than the alternative that we'll talk about. So if we could design a totally ideal drug for alcohol withdrawal, we'd want it to be first rapid onset for quick symptom control, vital sign improvement, especially if the patient is severely agitated or aggressive. We would want a long half-life, which typically provides a smoother withdrawal, fewer breakthrough symptoms, and with that comes a self-tapering effect as well. One study comparing oral lorazepam to diazepam, patients reported more comfortable withdrawal with diazepam, which has a longer half-life, and one study showing treatment with phenobarb, either alone or with benzos, had less bounce backs at 3 days compared to benzos alone. So suffices to say, long half-life is definitely a good thing. We would also want stable pharmacokinetics. So alcohol withdrawal affects patients of all ages, which comes with different drug clearance rates. We can have acute or chronic liver or renal dysfunction with that as well, which can affect drug metabolism. So a drug that affects all ages and comorbidities equally would be great. No drug interactions, no major side effects would be nice. Unfortunately, this doesn't really exist, so we try to do the best we can. This graph shows time to sedation for a few different benzos we might give in the ED. There is a much different graph for anticonvulsant properties, just FYI. So here you can see that diazepam is actually thought to be the quickest onset, which is why I earlier mentioned that if you're reaching for midazolam, it's probably just reserved for those severely agitated patients for IM use only. When we're talking about alcohol withdrawal, and you can see lorazepam actually has quite a delayed onset for something that we maybe give often for agitation. So main point here, diazepam is very rapid onset. You can see the durations down there. We'll talk about that more in a couple minutes, but this is just showing one single dose. So talking about lorazepam here, in the grand scheme of things, it's still considered a fast onset drug. Sedation starts at around 15 to 20 minutes, but the peak effect is around 30 minutes. So redosing should generally happen after at least 15 minutes to avoid dose stacking, which is when you give a second dose of a medication before the first one has its full effect. There was a study that showed more ICU delirium with lorazepam compared to diazepam, possibly due to the dose stacking phenomenon. The good thing about lorazepam, there's no active metabolites, so there is a more predictable elimination compared to benzos with active metabolites, but that also means that it's actually the benzo of choice in patients with severe liver dysfunction. Lorazepam is metabolized via glucuronidation, which stays relatively intact in elderly patients as well. It does have a shorter half-life compared to some other benzos at around 14 hours. Moving on to diazepam. So this has the fastest onset of the few drugs I'll talk about. Sedation starts within 1 to 2 minutes, but the peak effect is at 5 minutes or so. It is highly lipophilic, so you get rapid CNS penetration, but then afterwards you get peripheral redistribution. So this just means the first dose would have a much shorter duration of action relative to its half-life, but repeated dosing, you get peripheral accumulation, and the clinical effect approaches the half-life. Luckily, these patients with moderate to severe alcohol withdrawal typically require more than one dose of medication, so the effects of diazepam will end up lasting a long time. You can redose as early as 2 minutes, according to some sources. There are active metabolites made in the liver, which have very long half-lives themselves. In patients with cirrhosis, you can see a 2 to 5-fold increase in the half-life. And in older adults, you can see that the half-life is increased by 1 hour for each year of age. So in a monitored setting with some dose adjustments, this prolonged half-life in these subset of patients might actually not be that bad of a thing. So phenobarbital, relatively fast onset, peak effect around 15 minutes, thought to fully distribute in about 30 minutes, so redosing should probably happen somewhere in the 15 to 30 minute range. It's moderately lipophilic, but you don't worry as much about the peripheral redistribution like you do with diazepam, just based on its unique mechanism. It does have the longest half-life of these drugs I'm talking about in the realm of around 100 hours. It's contraindicated in advanced cirrhosis with hepatic encephalopathy as well as porphyria. In more mild forms of liver dysfunction, you might just want to consider lowering the dose a bit. So this is a more conceptual graph showing that you typically get sedation at a lower dose in a more unpredictable fashion from patient to patient with benzos, but clinically significant sedation from phenobarb and isolation usually occurs after getting to a higher toxic level. So there's actually a fairly wide therapeutic window for phenobarb in terms of risk of oversedation. So more on phenobarb here, 10 mg per kg, very unlikely to cause somnolence on its own. So that means without also having head trauma or high doses of benzos on board and so on. And because of phenobarb's stable pharmacokinetics, a 10 per kilo loading dose is going to pretty reliably correspond to a safe phenobarb level in the blood, which is well below the toxic dose that leads to any sort of coma. And this is one of the more common loading doses for alcohol withdrawal, so definitely a safe dose to give. You can give up to 20, maybe 30 mg per kg cumulatively, something that might be happening in the ICU, but is there if you need it in the ED. At this point, persistent symptoms, if you're giving the 20 to 30 mg per kg, suggests an alternate cause of agitation or delirium. You probably fully treated the alcohol withdrawal at this point, so you might want to move on from any sort of GABAergic drugs at that point. Phenobarb is very useful for the subset of patients that have benzodiazepine-resistant withdrawal. It doesn't require endogenous GABA like benzos do, which is downregulated in chronic alcohol use, and these resistant patients are very GABA depleted. So phenobarb directly opens that chloride channel instead of just increasing its affinity for GABA as with benzos. Phenobarb also inhibits excitatory glutamate signaling, which is upregulated in chronic alcohol use, so another good unique mechanism with phenobarb. And unlike benzos, phenobarb isn't really a good drug for treating nonspecific hyperadrenergic states, since you're not really giving enough to cause sedation. So it's really only beneficial in the context of alcohol withdrawal for that. There's no large randomized studies about this specifically, but there are some suggestions in smaller studies that phenobarb is safe in patients who are discharged from the ED. So what does the evidence say about phenobarb? Overall, there's no significant difference in safety with phenobarb or phenobarb when combined with benzos, which can sometimes be a concern for people new to using phenobarb, so it is safe. Some, but not all studies have shown reduced ICU admissions, lower intubation rates, reduced ICU or hospital length of stay, less delirium, synergy with benzos. So lots of potential good things. Unfortunately, there's no clear-cut standard phenobarb regimen for alcohol withdrawal, but as I mentioned before, 10 mg per kg seems to be a pretty common one out there. There are lots of different protocols out there. For example, some studies will reach a max dose of benzos, then add phenobarb. They'll use phenobarb as an adjunct to benzos. They'll give small symptom-triggered doses of phenobarb versus a weight-based loading dose, or they'll just use phenobarb entirely instead of benzos. For example, one study gave a 10 per kilo infusion as an adjunct to their normal lorazepam protocol. They saw reduced ICU admission, similar adverse outcomes, and overall decreased lorazepam usage there. Another study gave 10 per kilo phenobarb to patients heavily pretreated with benzos, and then 15 per kilo if they weren't, with 130 to 260 milligram PRN doses. So again, lots of different study protocols out there. We do have the SAEM GRACE 4 guidelines that can help us a little bit. It says here, adult ED patients with moderate to severe alcohol withdrawal who are being admitted to the hospital, we suggest using phenobarbital in addition to benzodiazepines compared to using benzos alone. And this is a conditional recommendation for with very low to low certainty of evidence. So while it isn't the strongest recommendation in the world, it is out there to give you a little bit extra confidence using phenobarb. If SAEM's very low to low certainty of evidence recommendation isn't convincing enough for you, I'll let the pharmacokinetics convince you. Phenobarb does seem to work very well for alcohol withdrawal, either by itself or as an adjunct to benzos. And speaking of benzos, I'd say use diazepam, again, because the pharmacokinetics just make a lot of sense. And for phenobarb, try to be reasonably sure that you're treating alcohol withdrawal, particularly moderate to severe alcohol withdrawal, and always beware of the contraindications. I would say feel free to start off with diazepam while you're getting a feel for the severity and the disposition, and for patients you're admitting, a 10 per kilo load of phenobarb might do them some good. And then just because there isn't really much data out there either way for discharging patients after giving phenobarb, just use your best judgment. If it's a patient you'd feel comfortable discharging with a Librium taper or something like that, you could probably feel okay discharging them after giving them phenobarb if you need to, potentially without any scripts for benzos because of the long half-life. So. And with that, that is all I got. I got some references and any questions?
I don't see anything currently in the chat, but I think we're currently like on time, so we'll keep the party rolling. Thank you,
Sure. Thank you.
Kamer, for walking us through that and selling us on diazepam and phenobarbital. Definitely something I'll be using like regularly, like moving forward for sure. All right, so next up here, we are going to go to our third talk before our first 5-minute break. This is going to be Dr. Justin Grisham. He's ultrasound director from Kingman Regional Emergency Medicine, and he's going to talk about POCUS and cardiac arrest.
Perfect. Thank you. I appreciated the rural emergency medicine call out. In addition to working at Kingman, I work at a couple critical access spots for the true Four Corners down in Cortez. And it's really interesting to see the switch when I try to call consults from each place. So I appreciated that call out. We're going to talk about some point of care ultrasound stuff, specifically in cardiac arrest. Let me see if I can do this. And then, sorry, share my screen here. Oh, I am sorry, I'm struggling to share my screen. I apologize. Give me 2 seconds and we will get this going. Well, my computer seems to have taken a giant dump on me. I apologize. Give me 2 seconds here and maybe we can get her going. And if not,
Justin, do you want Dr. Mendez to go right now? And you,
yeah, if that can happen, and I'll do some troubleshooting here. I apologize.
cool. All right, we're going to move on to Matt Mendez and we'll come back to Dr. Grisham. Thank you guys for your patience. Dr. Mendez is the director of didactic education from Denver Health, and he's going to share the Wheel of Flow.
All right. I just shared a whiteboard. If everyone could follow the whiteboard, and if there's any issues with people seeing it, just let me know in the chat and I'll just go ahead and get started here. All right.
Looks good, Dr. Mendez.
Okay, cool. Looks like everybody's on. So here we go. I lost my pencil. Trying to jump in and help. Here we go. I'm so sorry. Let me just try that one more time. Okay. If you can follow the new whiteboard and then just confirm that you can see it. I have all the doodle stuff up now and should be able to work.
Looks good.
All right, cool. So what we are talking about today is patient flow in terms of running your own zone. The target audience is everyone, but I'd like to frame it for the 3 different cohorts. So this talk was inspired by how the struggle when you're a junior resident to figure out how to keep things moving, see as many patients as possible, and then work towards that big E word, efficiency, that every resident seems to want to work on at the beginning of their shift. The way that this can help a senior resident is that this framework makes trying to teach something that is very nebulous a little more concrete. But by the time you're a senior resident, you're usually doing all of these things in your head at the same time, and you don't need this framework, but so I would encourage you to use this to teach. And then from an attending standpoint, the same thing is that senior role. If you're an experienced attending and you found difficulty in teaching efficiency, I think this framework can help. So we'll go ahead and get started. So this wheel starts assuming that you have just seen a patient. So the first thing that you're going to do after seeing a patient is you're going to put in orders, because nothing in the world can happen without putting in orders. And so we always make the joke in traumas, the RABC, so registration, airway, breathing, circulation, because nothing can happen until the patient is in epic. And orders are kind of the next phase of that modern ridiculousness of moving patients through. After orders, what we encourage is that this is the time that you write your note to essentially 90 to 99% completion. And if you are using dictation or AI scribes or any other hack, this should take you 90 seconds to write an HPI, physical exam, and then kind of a differential and brief plan. And then that last 10 to 1% at the end of the visit is just a summary statement and disposition. After you write the note and before you see any new ones, the next thing you're going to do is you're going to run your list in your head, and you are going to see if there's anybody that you can admit, because this process is often very rate limiting. And so the sooner that phone call or order or page happens, the more likely it is that you're going to be able to turn that room over and give yourself another patient and learning opportunity. After admissions, the next thing that we would encourage is that you look for the opportunity to discharge anyone. This is often much quicker than an admission because you just do the the visit summary, and then if you haven't updated the patient, then you can do that on your way to your next new patient. Then we go to what we call rate limiting steps. Let's see, rate limiting steps. So this is going to be things like an LP or a central line or calling a sniff, family combos, things like that. These are things that will grind a patient's visit to a halt, and the sooner you can address them, the better. And so then after that, once you have addressed all of that, the final thing, the number 6, which is problem patients. So this is the behavioral patient who is not a safety issue, but does need attention before you can safely move on to the next zone, or potentially a family member or somebody who needs an update and it is a contentious situation. We will talk about the safety issues here in just a second. And then, and only then, would we encourage you to jump in and pick up a new patient. And you could see in the first few hours of your shift that you're gonna skip. You're gonna put in orders, write your note, and then you're not gonna have any of this stuff to do. And so you're gonna do intake. You're gonna see way more patients in your first few hours. And then as you stack up patients, this is where this will get really important. So most junior residents, early senior residents are very good at the first few hours of the shift because intake is relatively easy. Having the discipline to do this is where I think you're going to make the rubber meet the road. The one thing that is super important about all of this is that safety issues and any critical care breaks this circle, and you immediately leave and you do something else. If you are writing your notes and there's a staff getting assaulted, obviously you're going to go address that and consider your high sedation dose ketamine intramuscularly. If you are in the middle of putting an admit order in and a trauma activation comes in that was unannounced and is just like an EMS walk-in, then you are going to have to obviously break that and address that right away. But otherwise, and most of the time, you can keep yourself within this framework and really keep your zone and your cohort moving. And then, like I said, if you are a senior resident or faculty member who is good at this stuff, but never really figured out how to draw it out for somebody, this is a very quick and easy thing that you can do at the beginning of a shift on a piece of paper, the back of an EKG, and just put it in front of the intern or junior learner's desk and encourage them to look at it after every patient encounter. This is how you can see the number of patients per hour in an RVU-based practice and go home with no notes that you need to be able to see to make the salary that you want. And Denver is a very challenging market with respect to all of that in terms of a compensation model and the patients per hour it takes to meet those desired needs. So we really try to hammer this home now. And I think that's it. I intentionally shortened it a little bit for some questions. If anybody has any questions or thoughts or reflections, I'm always happy to talk about this stuff.
Yeah, I guess question for me is like, how do you, when people are talking about kind of the priority of things and in your wheel of flow as you discuss it here, how do you resist the urge to continue to see new patients despite the fact that you feel like note writing? Like, what is your argument for number 2? Write your note first, because I think that's something we talk about with people all the time, right? What to you is like the selling point for writing your note up to 90 to 95% before moving on to the rest of your care?
For sure. Yeah, I appreciate that. So the note is essentially a medical procedure. If you think about it, it communicates a lot of information to a lot of people. and it is absolutely necessary for patient care. And like in most places, you're supposed to have them done by the end of your shift and like within 48 hours. Now, whether how much they enforce that tends to vary, but that is generally the rule of thumb. And if you can think of the note as a critical action for patient care, you can convince yourself that it should be prioritized. And then there was a question in the chat that was, where does presentation to the attending happen? That's a great question. It tends to, where I work, it tends to happen at every stage of this circle. It's whenever everybody's back at the desk and you can present. We have a couple zones where we're one-on-one with a resident, and so it's just a pair, and it tends to happen right after they write the note. And this is new for us over the last 2 years, but we are intentionally not annoying them to present to us so that they have the 90 seconds to 3 minutes to get a decent note in, and then they can present and then move on. And then usually what happens is they either want to run the board and then we come up with a plan for the rest of this wheel on everybody on the board, or you do it in your head, which is what you'll do when you're not in an academic setting. You'll just write your note, go back to your track board, run the board in your head, and execute these as you come upon them. And then the other tip is we really encourage running the board and organizing your track board in reverse time if that's possible.
And then we have another message in the chat from Rube. She's like talking about just like making transfer calls. I guess what other things do you foresee? Like, I know this is the broad overview, like including things like making transfer calls and doing like other emergency department specific tasks and procedures. Like, where do you feel like they slot in? Is it mostly all in the rate limiting steps box as you're typing here?
Yes, I think so. I think if it's not critical care, right? So the central line, that is not essential, but the ICU is making you do it before they'll accept the patient. But like obviously like an intubation or something else emergent, you break and you do that, doesn't matter where you are. I think everything else, yeah, would fall into this steps, into the rate limiting step here in 5. In when we have to transfer people from our outlying sites, which is not rural, it's suburban, the process is somebody calls and gets the thing started for you, and then it's almost like an admission. Then you take the call when they call back. So you could theoretically put like a transfer call depending on your system's approach to transfers in the admission type area.
Okay, cool. I think we will put a pin in that. Thank you, Dr. Mendez, for walking us through like this approach and the paradigm to patient flows. We appreciate that. We are going to move on to our break. We're going to be back here in 5 minutes time.
Dylan, do you mind if I do a quick screen share trial? How is that? Is that visible? All right. My residents say they can see it, so I'm going to count that as good.
Cool.
Justin, can I ask you a question?
Yeah, please.
When you did the screen share, are you able to see your slide notes?
I don't have it set up that way.
No.
Because traditionally I have struggled to see that. It's easiest if you have 2 monitors. I'm on my laptop right now.
Oh, I don't have that. Okay.
Yeah.
Thank you.
If you're using PowerPoint and you want to see your presenter notes on a single monitor, what I've found is that the trick is when you click share is not to pick the first window that pops up, because if you have multiple desktops or multiple windows open and you scroll down a little bit, once you click that share button, you can pick what screen you want the audience to see. So you click the screen that looks like just your slide, and then that's what the audience will see, but will project on your laptop will be the presenter view with notes. That usually does the trick.
So scroll down when I hit share, look down towards the list.
Yeah, you'll hit share and then a window will pop up and it'll ask you which window you want to share. Most people just click the first one.
Right.
If you scroll a little bit, there should be a few different options, and one will look like just your slide. That's what'll get presented, and then your PowerPoint should stay in view on the Zoom desktop.
Got it. Thank you.
All right, let's dive back into this thing. Welcome back, everybody. We are going to go round two with Dr. Grisham here. He, once again, is the ultrasound director from Kingman Regional Emergency Medicine, and he's going to be talking about POCUS and cardiac arrest. Dr. Grisham, you have the floor.
Wonderful. Thank you. I appreciate the patience. Ultrasound fellowships are actually just PowerPoint technology fellowships, and apparently I need to go back to them. So we're going to talk about point-of-care ultrasound in cardiac arrest. I am an ultrasound dork, but I try to be a very reasonable ultrasound dork. My goal with this is for you to walk away with kind of two new things that you can do to hopefully make your codes go a little bit smoother. I have a firm belief that as ER docs, we should be the absolute best at resuscitation and running codes in any hospital anywhere. I think a lot of us see this pretty routinely. I work in spots where we run codes even in the cath lab, and I think that says a lot when we're the ones running the code. I always think we can do it a little bit better, though. So I also feel very strongly against the merit badge courses, and luckily, a lot of our professional organizations, including AAEM, have strong position statements on this, saying that as residency trained emergency medicine physicians, we are trained beyond the level of ACLS, and there's a lot more stuff we can do. I agree with that. I think ultrasound is one of those things. So let's talk about what works in codes before we start talking about ultrasound. What we know works in codes is early aggressive compressions, early defibrillation appropriately, probably after you do some compressions, continuous compressions if you have some sort of airway device in place, continuing CPR immediately after you defibrillate a patient. And then finally, what we're going to talk about is using carotid ultrasound for rhythm checks. I think we should change our verbiage around our codes and that we are doing rhythm checks, not necessarily pulse checks. And one of the ways we can do that is by starting to incorporate point of care ultrasound. Going back to first principles, so if you delay compressions within CPR, your patients die. And that's what it boils down to. Our ROSC rate decreases by 1.4% per minute, and it's likely greater than that. So we have a 15.6% survival. This was out of hospital cardiac arrest data when CPR is started within 3 minutes. If it's delayed 14 minutes or more, our survival, quite frankly, goes to hell. I worked in a spot in Denver, a Good Samaritan, that had wonderful CPR in hospital ROSC rates. Part of the reason was they enabled every single person in that hospital, every employee, from the cafeteria workers to the ER docs, to do CPR as soon as you think they need it and not delay. And I think that went a really, really long way. Our EVS people in the ER had multiple saves themselves. They all loved doing CPR. It was great to see. We know that if we delay defibrillation, that our patients are less likely to get ROSC and more likely to die. As we go through this presentation, there's a bunch of QR codes. You can scan those. It'll take you to the studies that I'm talking about. Easier than some citations. Do good compressions. Shock them if they need it. Okay. Our goals in cardiac arrest, and I think we should keep this really, really simple. We're doing high quality chest compressions. We're doing very, very short rhythm checks. We're appropriately defibrillating patients, and then we're addressing reversible causes. With this, we can use ultrasound to shorten our rhythm checks by quite a bit and address reversible causes. I think shortening the rhythm checks is the best reason to use point of care ultrasound within cardiac arrest. So how we're going to do that? We are going to simply ultrasound the carotid. It's really easy. It doesn't take any time and it can shorten stuff up quite a bit. So this is the study that I'm talking about. This slide is from the Ultrasound Gel podcast, which is a great literature review. We're going to get a single ultrasound image on the neck that includes both the carotid artery, the jugular vein. You're probably going to get some SEM in there, but as long as we can see the carotid artery and the jugular vein within our image, we can get this before our rhythm check. We can see this. We're going to compress these enough that the jugular vein is completely compressed. And quite simply, when we do our rhythm check, we're just going to look for pulsatility within the carotid artery. There's no guessing here. There's no trying to find a pulse. 4 people have their fingers, 2 on each, 2 on the carotid, 2 in the femoral. Everyone's like, oh, I think I feel a pulse. Oh, maybe I feel a pulse. There's none of that. We don't have to guess anymore. All we do is we look at the carotid artery and we see if it's pulsatile. I don't use Doppler. Some of our attendings do. I think that's reasonable. I just look at the carotid. All right, so this is what it looks like. We obtain the view, that's on the left, right? I can still see the internal jugular vein. It's patent, it's open, and then I compress it so the jugular vein is compressed and closed, and then I can look for pulsatility within the carotid artery. You can get this view well before your rhythm check starts. All right, now moving on from this, and we'll come back to this, but I have seen a trend where people attempt to do subxiphoid ultrasound within cardiac arrest. I think my residents know I will hit them on the head with an already broken ultrasound probe if they try to do this. Why? Because it takes way too much time. We know that if you get the images beforehand, you can shorten this, but we're still talking about a greater than 10-second rhythm check, and sometimes as long as a 30-second rhythm check, often with these subxiphoid images. Now, I think there's ways to do it in which we can do it fast enough, but these rhythm checks are way, way too long and likely decrease our ROSC rates. I think we should be trying to keep our rhythm checks to 4 seconds or less. We can talk about some ways that ultrasound can help you block that time out. So I won't be doing subxiphoid ultrasound unless I can get a very, very fast image ahead of time and it's timed. Okay. The way I do that is I set all of our ultrasound machines to either a 4-second or a 6-second video clip. As soon as we pause compressions for our rhythm check, I'll start that timer. I will get the image and I will only ultrasound for as long as that timer is going. As soon as that clip is done, we restart compressions. If you don't get the image, you don't get the image, move on. And that way we're not waiting too long and having these really, really long rhythm checks where we know that coronary perfusion has dropped to absolutely nothing. So here's my flow and how I've been using point of care ultrasound within these. So our compressions are ongoing. For 30 seconds before the rhythm check, I start getting the carotid view with a linear probe. 15 seconds to rhythm check, we pre-charge the defibrillator. We do our rhythm check. I look first for carotid pulsatility. Second, I look at the monitor for a shockable rhythm, and then we immediately restart compressions. If you can set your ultrasound screen up right by your Zoll or whatever monitor you're using, you can see them both in the same view, and these are really, really short rhythm checks. As short as 2 to 3 seconds, and then we're back on the chest and going for it. And it works really, really well. All right. Summary in which I want you guys to walk away with. You can do a carotid ultrasound for each and every rhythm check and keep your rhythm checks really, really short. I will do one subxiphoid view looking for reversible causes within cardiac arrest as long as I can keep that view to a 4 to 6 second kind of acquisition time. I don't do any interpretation of that view real time. I'll look at that video as soon as compressions have restarted. That way we're not delaying any time. You can set your ultrasound machine to either a 4 or 6 second video clip as a hard stop. And we're still prioritizing compressions and defibrillation because, quite frankly, that is all that really works. Okay. So if you guys have any questions, please email me. If you want to argue about ultrasound stuff, also please email me. I'm always happy to dork out about this stuff. And I think we have a few minutes. I'm happy to take any questions or we can move on.
Basically, Dr. Krishna, while people are like thinking might be questions to ask you, we do have a couple minutes here, as you said. So I guess what is your like thoughts on like femoral POCUS for POCUS pulse check, like POCUS rhythm checks? And then like how do you know the pulsatility that you're seeing is a perfusing like rhythm or perfusing pulse?
Absolutely. Great question. So I prefer carotid over the femoral, mainly because, especially if we're working in kind of one of the critical access spots, I'm probably already at the head of the bed anyway for a lot of these. My thought being if I can see a visible carotid pulse there's likely perfusion to the brain. I feel more confident about that than a femoral pulse that I would see. Right now, we don't have, I think, an accurate way of truly saying, yes, there's perfusion. I'm not sure we have that with feeling for a pulse either, which is how I reassure myself. But I do think that's going to be some of the future is probably measuring VTI or something else similar to that.
Okay.
Was there another question that popped up? I'm having.
Yes, there's a this is do you have any tips and tricks for obtaining adequate cardiac views during pulse checks, considering all of the monitor stickers and subcutaneous air interference, or do you just stick to the carotid?
So I'll do the carotid for each rhythm check. Like I said, I'll do one attempt at a cardiac view to address reversible causes. And don't be afraid to get some of the alternate views. So while they're doing compressions, you should still be able to get some sort of view. And if you can't, look at another window. Sometimes it's the parasternal long axis view. There's actually some data that that's an easier and faster view to get. Sometimes it's a four-chamber view. If you're spoiled, which we're not, and you have TEE, that's the easiest because you can just do it during. But don't be afraid to go look for other views, but also don't waste time looking for those views. I don't do death confirmation with ultrasound because sometimes you can still get some what looks like semi contractility and it can really confuse the picture, especially if there's family in the room.
In the chat, somebody is taking it to the next level here. What do you think about pulse wave Doppler, and is that a good way to assess perfusion at this point?
I think we're getting there. I think there will probably be things like VTI measurements, which we're already using in resuscitation to check for perfusion. I think that'll be the next step. I haven't seen any convincing data on it. If someone wants to get some data, I'm happy to help.
I think that's about it for questions. No, thank you, Dr. Kudrum.
My pleasure. Thank you, guys.
And then Dr. Ivan, we're like 2 minutes early, but if you're ready to roll, we can introduce you. Up to you.
Yeah, no, I'm ready. Let me get my video going. Sorry. One second.
Yeah, do your thing. While you get set up, I'll let everybody know all about you. So we have Dr. Yaron Ivan. He's host founder of the PEM Rules podcast and director of pediatric emergency medicine, like resident education with the Sunrise Health GME Consortium Emergency Medicine Residency Program. He is presenting PEM Rules for the general ED physician.
And you guys can see my slides now?
Yes.
Awesome. Hold on one second. All right. Good morning, everybody. Yes, my name is Yaron. I'm a pediatric emergency doctor at Sunrise Children's Hospital, and I have some other gigs that I do on the side, but I still work full-time clinically. I love my job. Being pediatric emergency medicine doctor is the best job in the world. Anyhow, so this is a lot of my philosophy and just the way I practicing pediatric emergency medicine, which is like the main idea behind my podcast, PEM Rules, Pediatric Emergency Medicine Rules, which is a double meaning. And you can find me in all those platforms. I have no relevant financial relationships to disclose. I wish I did. And the goals and objectives for today, I'm going to discuss some common rules. They're more like advice that I find helpful when practicing pediatric emergency medicine. I'll explain what they mean to me and how they help me and how I use them. And really, like a lot of them just help me give what we call anticipatory guidance. I think in the general EM world, you guys call it discharge instructions.
I'm sorry to interrupt, Dr. Ivan. We can't see your slides anymore. Did you stop sharing?
Sorry. What did I do wrong?
I think you just stopped screen sharing.
I did? Okay, hold on. You see it now?
Yes.
Okay. So we're basically going to discuss my rules, my advice, my philosophy for pediatric emergency medicine. A lot of it has to do with talking to patients, not necessarily doing anything. Because as a pediatric emergency doctor, really what I do is convince the parents that their child is fine most of the time. And that is actually an important part of what we do. So we'll go case by case. And by all means, I'm happy to accept questions at the end. Case number one, you're seeing a 24-day-old infant who's presenting with a fever. You start the full septic workup, and this actually happens quite often because our nurses are great in grabbing that respiratory virus PCR, RV-PCR. And before I even finish all my workup, the RV-PCR is positive and the kid has a virus. So the question is, what do? You haven't done your LP yet. You haven't finished the workup. And PEM rule number 1 basically says, and this is very important, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. So if you think about it, this is the most important PEM rule, because what does respiratory viral panel positive really mean? It means that the patient has a benign viral illness that you cannot do anything about, and they're going to be fine as long as they're taking PO, respiratory is fine, etc. You really did not prove the patient is not sick. The AP guidelines, and before the AP guidelines, the Rochester criteria, the Pittsburgh criteria were always very focused for a very good reason. The job of the guidelines is to rule out bacterial illness, not to rule in a viral illness. In the past, we weren't able to rule in viral illness. Now we can in a minute and a half with respiratory viral PCR, but that's not the goal. PEM rule number 1, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. Full septic workup should be completed. And I always remind my residents that full septic workup really means the nurse is doing everything and you are just doing an LP on a little chicken. Like, it's that easy. It's no time from you. The nurses really run the show. It's not worth cutting corners. And you're not going to listen to me. You hopefully going to listen to the literature. And here's a paper from 2018. Thousands of infants who were febrile. Several of them, many of them, had viral PCR, and 55% were positive for one respiratory virus. Specifically, human rhinovirus was the most common, 35%, and bacterial infection was identified in almost 10% of them. Febrile infants who were positive for human rhinovirus were actually more likely to have bacterial infection than those with non-human rhinovirus. And you can see the percentages with a significant p-value. They concluded in their paper that human rhinovirus is common in febrile infants. Detection did not alter the risk of concomitant UTI at any age or the risk of bacterial infection, invasive bacterial infection in infants less than 28 days old. So PEM rule number 1, super important. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. The respiratory viral panel is a terrible test. It helps us rule in a virus that we cannot do anything about and is totally benign. That's not the goal. The goal is to rule out bacterial infection and to prove that the patient is not sick. Now, I don't think that rule is very pediatric specific. Viral PCR, again, is a useless test in the EM world. Exceptions do exist. If you're seeing a child in front of you with leukemia and he or she have a fever, it will be important to know if they have influenza, because influenza is a treatable condition, and influenza in a child with cancer is a serious condition. So obviously some exceptions exist, but otherwise the viral PCR is a useless test in the PDM world because you're proving that the patient has a benign illness, and that's not your job. And I don't think, again, this is very specific rule for pediatric emergency medicine. I am sure that all of you, when you see a 70-year-old with chest pain, you prove that he or she do not have an MI. You don't diagnose costochondritis because they're tended to palpation. So it's not really PEM specific. Case number 2, 23 months old, presenting to the ED, complaining of runny nose and congestion, and mom is very, very worried. She says he gets sick all the time. And some parents actually do say, doctor, I don't think his immune system is working. I think his immune system is off. He's always sick. He gets fevers, runny nose, congestion, vomiting, diarrhea, missing tons of daycare. And the question is, what do you do? What do you say? And PEM rule number 1 is very clear. The single most important indicator that a child or a baby is healthy is weight gain. And even in our very old EMR at my hospital in Vegas, you can usually find the growth chart. And if the baby has been on the system enough times, you can see the growth, or you can ask the parents if the PCP mentioned anything about it. But a baby that is growing is very unlikely to have an immunodeficiency or any other serious medical condition. So check the growth chart and then reassure the parents. 90% of children have 8 viral illnesses every year. For a 2-year-old, a viral illness is easily 103, 104 fever, a week of symptoms. That's 8 weeks, 2 months that the child is symptomatic with a viral illness, fever, vomiting, diarrhea, cough, congestion. 10% of children, unlucky children, have 12 viral illnesses every year. That's 1 a month, where they're symptomatic again every month for a week. That's very common. That is standards. And again, remember, zebras do exist. It's very rare, but some patients out there do have an immunodeficiency, and that's why they're sick all the time. Again, those are very rare, and those kids have failure to thrive. It's not like they get 10 viral illnesses a year and recover. They have kidney problem, liver problem, they're dysmorphic, failure to thrive, etc. They're not normal kids who get over their viruses. This is what you want to see. And again, this is available in most EMRs. You just have got to find it. This is a child that has been on the 75th percentile all of his life, all of her life. They're growing. If you see that on the 5th percentile, but the kid is growing, that's okay too. What you don't want to see is a patient that is falling off the curve. Case number 3 is a 5-month-old presenting to the ED with complaint of frequent spit-ups. This is probably one of the most common chief complaints I see. Mom is worried, and she says that he's spitting up everything. Everything he eats comes up. So again, what do you do? What do you say? How do you work up those patients, and how do you reassure those parents? Those parents are often very worried. And PEM rule number 6 says, I call it the white rule. Babies, newborns are only allowed to vomit white stuff. Anything bloody or anything green, you possibly have a disaster in your hands. So I tell the parents, as long as your baby is vomiting white stuff, like the stuff that just came into his mouth, then that's okay. I really, really don't recommend, especially as ER doctors, to drive the parents crazy and start on what I call the formula roulette. I tell the parents, if little Johnny is not spitting up blood or green, has no blood in the stool, and he is growing, going back to the previous rule, that is the right formula for him. Just because the baby is crying, that is not the reason to change the formula. I apologize. And again, I see that all the time. Parents really drive themselves crazy. We're changing the formula. All formulas, with the exception of very few, 2 or 3 of them, are milk-based, and they're almost all the same. So giving reassurance is very important. And again, zebras always exist. Exceptions always exist. Just as an example, if I see a 5-month-old, and that does happen, a 5-month-old, a 4-month-old with hematemesis, and he or she look fantastic and have a normal exam, I ask the mom if she's breastfeeding, and the mom says yes, and I apologize. And I ask the mom if she's bleeding from the nipples, and if she is, then the kid has hematemesis because he or she are literally drinking blood. Blood is an emetic agent, and you're going to vomit blood. So under those circumstances, it's even more reassuring. No workup, nothing that the patient needs. Case number 4, 3-month-old presenting to the ED with complaint of constipation. Again, very common chief complaint. Mom said he hasn't had a bowel movement in 4 days. He's fine otherwise. He or she are feeding, peeing, not fussy. Everything else checks out fine. So the question is, what do you do and what do you say? And this is super confusing, but PEM rule number 8 is actually called the rule of 7. 7 bowel movements a day or no bowel movements for 7 days is normal in a newborn. And I can't stress that enough. I wish that is something that the doctors upon discharge will tell the parents, because I see that complaint all the time. Babies do not have to poop every day, by all means. Again, exception exists. So as long as The white rule is not violated. In other words, the baby is not spitting up anything green or anything bloody. The baby is growing. Again, the single most important indicator that a newborn is healthy is growth. Again, I don't recommend the formula roulette just because of that. I got to be honest, one of my colleagues in Florida used to call it the rule of 10. She was very generous. 10 bowel movements a day or no bowel movement for 10 days. She also didn't do anything for those patients. I call it the rule of 7. That's what I learned, but I don't think it's unreasonable. If the baby hasn't stooled in 8 days, but everything else checks out fine, I would not give them an enema and I wouldn't do anything differently. Again, zebras exist. You got to get a good story. You got to ask the right question. Specifically for those patients, those parents, I always ask, Mom and Dad, every newborn baby before they leave the hospital, they have to stool at least once. Did your baby do that? Because if the answer is no, maybe you have a case of Hirschsprungs in your hands and you have to worry about it. So asking that question under those circumstances is very important. Case number 5, 7-year-old presenting to the ED complaining of a red, itchy rash. Super easy. You make the diagnosis of hives. What do you do? What do you prescribe, if anything? And what do you say? And this, to me, as a PEM doctor, is probably one of the most over-medicalized problem that I see in kids. This is PEM rule number 27. I tell my residents, when you speak to parents, you got to set up the expectations. So what does Benadryl really do? Benadryl blocks histamine, but I see this all the time. If the kid is taking Benadryl, but he or she are still exposed to the allergen, what is Benadryl going to do? Probably nothing or very little. So I always give Benadryl, and I recommend Benadryl for kids with hives, but I always set up the expectations and make sure that parents are aware. Mom and Dad, your child is allergic to something, and he or she will get better when that something is out of their system. Until then, I certainly recommend you give Benadryl, but Benadryl may not do a whole lot. If you just got a dog and the kid is allergic to the dog, as long as the dog is still around, he or she may have hives despite the Benadryl. So I don't give steroids. I don't make it a big deal. Less is more, but I make sure they understand that Benadryl may not cure the problem. So setting up the expectations is a very important rule in the PEM rule world. My favorite example for this rule is bronchiolitis. The AAP guidelines are very clear. A child in the winter, less than 2 years of age with wheezing, has bronchiolitis, and albuterol is not recommended and never indicated. I'm never against the parents using it, but I set up the expectations. Mom and Dad, here's a medication that supposedly doesn't help. All the research showed that it doesn't. If you want to use it, go ahead. I still recommend you suction your baby when you think there's difficulty breathing before you try albuterol. I see a lot of teenagers with migraine, and I treat them very passionately, and I love my patients, but I make sure they know. I set up the expectations. Hear me out, buddy. If you're going to spend a lot of time on your iPhone, on your iPad, video games, you're going to get migraines. So I'm all about the migraine cocktail at home or in the ER, but you got to set up the expectations. Another example for setting up the expectations is when you're seeing the 16 or 17-year-old female who coming in with abdominal pain and there's some red flags. Again, setting up the expectations goes a long way. Mom and Dad, I'm glad you brought your daughter. I agree with the concern. Just so you know, figuring out abdominal pain in a teenager girl may take a little bit of time. We need to look at the appendix, the ovary, give fluids. You might be here for 4 or 5 hours. I apologize. I feel like if you don't say that, 2 hours later, you have a very angry parent and a very angry patient. So PEM rule number 27, set up the expectations. Case number 6, 7-year-old presenting with abdominal pain and vomiting. Vital signs are normal. You do your CBC, and with your history, physical exam, and CBC, you calculate the pediatric appendicitis score. It's 3. Unlikely appendicitis, consider other diagnosis. You make the diagnosis of gastroenteritis, and you discharge to follow up with the primary care. What must you say prior to discharge? And PEM rule number 63 says that parents, families need to know 3 things upon discharge from the ED. This is super important. What is the problem? What to do for the problem? What to come back for? Again, takes 2.5 minutes. I try to make that as a rule for 100% of the parents or the families that I discharge. What is the problem? What to do for the problem? What to come back for? This is in your best interest to be very clear for the parents for anticipatory guidance. It is still possible this child has appendicitis. Parents need to know exactly what to come back for. It's worth every minute for the well-being of the child. None of us likes to see the same patient 2 days in a row. It's always a little bit anxiety provoking. You don't want those unnecessary ED visits. You want the parents to know exactly what to come back for and what not to come back for. For example, I've had parents come back because now the fever is 102, not 101, stuff like that. It really leads to a lot of parent and patient satisfaction when we give clear reasons to return and prevents those bounce backs that none of us likes to have. So those are just some of my rules. You can find more on the website and on the podcast. And this is my email and my cell phone. I am very passionate about pediatric emergency medicine, and I always understand that general ED physicians sometimes don't see a lot of children, and it's very anxiety provoking for some. By all means, you can contact me anytime. And thank you very much. If there are any questions, I'm happy to take them.
Thank you, Dr. Ivan. Appreciate you.
Yes.
Yeah, thank you for walking us through that and providing us, seems like only a few of many of your PEM rules. I wish I could read the entire,
Yes.
maybe we can access that online or something and send that to people's way so they can review it in its entirety. So let's move on to our next speaker, the last one before the next break. This is going to be Dr. Christina Domensky, Assistant Professor of Emergency Medicine with the Kirk Draconian School of Medicine at University of Nevada, Las Vegas. She's going to discuss Twinkies and tianeptine tour of gas station pharmacy.
Hi, everyone. Welcome to my pharmacy. It's a little questionable. I'm coming to you from the fabulous Las Vegas, Nevada, home of all the weird drugs, which we're going to learn about today. Can you see my slides okay?
Not yet.
Should be sharing my screen. There you go. You got it up?
Beautiful.
Perfect. All right. So let's get started. You've probably heard of gas station pills. It might have been from a patient, might have been from your friend, it might have been from reading about them in the news. But you probably wondered what these are, what is in them, and most importantly, how do I get them? So that's what we're going to find out today, and we're going to start with where to get them. First of all, you don't even need a gas station. You can find them in liquor stores, you can find them in bodegas, you can find them in the general store, a little convenience store in the strip mall. And generally, the less gentrified the area is, the better your selection. Once you find your store, they're not with the medicines. Don't find them next to the Benadryl or the Tylenol. They're usually behind the counter, somewhere near the cigarettes, or at the cash register, in direct view of the cashier, because people like to steal them. And they come in a big variety of flavors. There are some that promote energy and wakefulness, some that will enhance your sexual performance, some that say they're for pain relief, sleep, relaxation. And then there's this term called nootropics, which really just means like a cognitively better version of you. How do I know all this? Well, because in order to make this presentation, I went shopping. I went all around Las Vegas and tried to find some of these supplements, and I was able to get some products that we're going to talk about today. So what's on our specials? We have three products to discuss, and the one we're going to start with is this supplement called Rhino. Now, if you can't tell by looking at this artwork of a rhinoceros charging through a nuclear cloud, it is actually designed to enhance male sexual performance, and it retails at $7.99 a pill. We have some information on the back of it, which you can see a little bit more clearly. Number one, it is natural, and it is made in the USA. Well, so is the poop I took this morning. Just because it's natural does not mean it's safe, and doesn't mean you want to eat it. There's also this statement about the FDA that has not evaluated this product and that it's not designed to cure or prevent any disease. So why is that on there, and what is the role of the FDA in all of this? It turns out the FDA regulates human and veterinary drugs, medical devices, food, cosmetics, tobacco, and things that emit radiation. Where do supplements fall on that? Looking at the website, it turns out supplements are a subset of foods. And actually, the responsibility for ensuring safety doesn't lie with the FDA, it lies with the manufacturer of the supplement. The FDA can take them off the market and pull them and ban them, if they're found to be toxic or mislabeled, but that happens only after the product has been on the market a while and people have made complaints about it. The FDA can also regulate claims made by the manufacturer. So the manufacturer is allowed to make functional claims, but not health-specific claims. You can't say the supplement cures cancer, but you can say it improves sexual function or enhances sexual function. So it's this little gray zone for supplements, and most of the responsibility lies with the people making them. So what's in our Rhino? We have a list of ingredients here. We have your himbine, and that's actually a herbal product that is an alpha-2 antagonist. The net result of that is increases norepinephrine, so it's actually an energy booster. It's found in some pre-workout. So far, so good. We've got L-arginine, which is an amino acid. We've got zinc, copper, manganese, which are metals. We've got red ginseng. And then things start to unravel a little bit because we see this thing on here called soy paleto. I don't know what that is. When I first saw it, I thought it was somebody who speaks Spanish having a laugh because paleto means hick. Facepalm, don't know what this is. It's probably a misspelling of saw palmetto, which is a herbal supplement that's sold to enhance prostate health. So now I don't trust these guys because they can't even spell. And then we have these two things at the bottom, which look like they came out of Harry Potter. They're listed as two separate ingredients. And it's probably just one thing. It's like a herb called Tribulus terrestris, which is otherwise known as the puncture vine. This actually does have some evidence behind it, albeit in rats. If you give male rats Tribulus terrestris, they have increased mount frequency and a decreased latency periods between humping the female rats. Very little actually to support it in humans. We like things to be somewhat evidence-based here. So we have so far a herbal supplement with some amino acids and some metallic stuff and not really that much evidence, but people are buying it and the people say it works. And it turns out it's because people actually put Viagra in it. These guys got in trouble with the FDA last year in July because the supplements were tested and found to contain sildenafil. So all the stuff that was supposedly herbal was actually just straight up prescription medication that was being bought over the counter. And it's not the first time. This has been going on since 2018. They've had multiple instances of the same brand Rhino getting in trouble for putting Viagra in their herbal supplements. And one of the distributors actually was jailed for 4 years for distributing this stuff. This is a problem because the patients that are going to get this stuff are the ones who have been denied Viagra by their PCP. That's usually for good reason, right? They're usually on a nitrate or something that can interact with it. Viagra can interact with a whole bunch of things, including some HIV meds and alpha blockers, can cause profound hypotension. If that guy goes and gets this Rhino stuff and takes it, he's going to come to you profoundly hypotensive, right? That's not good. It can induce priapism in people that are prone to it, which you're going to have to drain. And it can actually act as a stress test in people with bad CAD and CHF. There's actually a case report of somebody who took this Rhino stuff and actually ended up going to cath lab with an RSA occlusion that was unmasked by him taking the supplement. So just because it's herbal, just because it's natural, doesn't mean it's safe, and it may not actually be herbal or natural. It may just be hiding prescription medication that you need to know about. So our next supplement is this magic mushroom chocolate bar. This one I was actually able to get without even showing ID, which is interesting. Here's a back thing, and we have the FDA disclaimer again, because it's not really a medication, right? It's a supplement or a food. We have our ingredients list. If you can't read that, the active ingredients are listed as B vitamins and something called a proprietary nootropic mushroom blend, which is extremely vague. And I went down a rabbit hole trying to find out what the stuff actually is. There's a lot of labeling on this product, which really implies psilocybin mushrooms, which are a Schedule I substance. The word magic mushroom on there, most lay people think that is a psilocybin-containing species. And it's got the word microdose in there, which is put around with the same sort of group of mushrooms. It's got this very trippy psychedelic artwork with the lips and all the colors. And then it's got a warning saying, don't take it with antidepressants, which implies there's something going on with serotonin. And then you've got this mushroom graphic on the front, which kind of bothers me a little bit because I'm a little bit of a tox nerd. It's got the shape of a psilocybin mushroom, which is the one on the left, right? It's got that conical cap and that very thin stem. But then they've drawn spots on the cap too. And the spots on the cap are typical of this another hallucinogenic mushroom called Amanita muscaria. Now, this guy has a completely different mechanism of action to the psilocybin species. The Amanita muscaria are actually legal to buy, possess, and eat. So you can actually buy gummies of them. And this guy is actually very clearly labeled Amanita muscaria on the front. It tells you exactly what is in this mushroom gummy. When you look on the manufacturer's website, they've gone to great lengths to tell you this doesn't contain any mushrooms at all. It's got none of the compounds found in the Amanita muscaria mushrooms and none of the tryptamine-like compounds found in the psilocybin mushrooms. They've run a mass spec on batches and put the results up on their website. They also put up cannabinoid results. It doesn't contain CBD or THC. It doesn't contain similar stuff like that. Eventually, on the website, I found this proprietary mushroom blend. It's not very exciting. It's got 5-HTP, which you can buy as just in your grocery store as a supplement. It's a serotonin precursor. People use it off-label to like supposedly help boost the serotonin levels. It's got some pretty inactive mushrooms like lion's mane in there. It's got some herbal stuff and B vitamins. So none of this looks particularly exciting, right? Why is this chocolate bar so special? Why are people using it and eating it? It turns out the California Department of Public Health decided to look into it, and they ran their own mass spec. And they found some different things in there. They found 4-acetoxy-DET and 4-acetoxy-DMT. Probably haven't heard of those. These are actually structurally similar to psilocybin. You can actually see the structures in the bottom right of the screen there. Psilocybin is the compound that's found in hallucinogenic mushrooms. If you eat those mushrooms, your body converts that psilocybin to psilocin. It knocks the phosphate group off, and that's why people who take the mushrooms don't actually feel the maximal effects for about 1.5 to 2 hours, because your body's got to process it. The 4-acetoxy-DMT acts in a similar way as a precursor to psilocin. Your body processes it, metabolizes it, and creates the same compound as you would have if you'd eaten the mushrooms. And the 4-acetoxy-DET is another orally active tryptamine, so they work together. And what these are going to do is produce a high that is very similar to a psilocybin mushroom high. It's going to last probably about 6 hours. But that's all that we really know about it, because there's not that much data on these drugs out there. We do know that psilocybin is pretty safe as far as overdoses go. People get sick because they do stupid things on it rather than because of the compound itself. But we don't know much about these guys. As far as legality goes, psilocybin and psilocin are Schedule I substances. They're federally illegal. They are decriminalized in some cities, but for the federal part, they are not legal to have our own. This is a strange thing about mushrooms. They fall into this odd area where the spores on the bottom right there, don't contain any psilocybin at all. So it's completely legal to buy and sell the spores. Once you grow them and create the fruits that contain the compounds, then you're breaking the law. So what about this 4-acetoxy-DMT and 4-acetoxy-DET? Those are research chemicals. So you can sell them, you can possess them as long as they're labeled not for human consumption. But the courts can go after you even if you have that label on that this is not for human consumption, but you are inferring that they are for consumption, like putting them in the form of a chocolate bar that has a recommended dosage of however many squares and a calorie content on there, then you're crossing the line, right? They can go after it because it's very clear this is obviously designed to be eaten. And once you do that, you fall under the Federal Analog Act, where if something is chemically similar to a Schedule I or II substance, it's essentially treated the same. So this chocolate bar is falling into a very sketchy area, and I did actually get rid of it. I didn't keep that chocolate bar with me at all. What are you going to see in the ER if somebody eats one of these? Probably similar to cannabis edibles. The main problem is not the compound, it's that people eat too much of it because people are greedy. If I see a chocolate bar that size, I'm going to eat at least half of it, not 1 or 2 squares. And people don't read the ingredients. They don't wait for that 1.5 to 2 hours for the metabolism of the compound and the absorption. They don't think they're high enough, so they'll take more. So you'll see people that are just too high. That's going to be the main problem that you see. For those patients, you're going to do a lot of supportive care. You're going to place them in a low stimulus environment. You're going to use benzos and antipsychotics as needed, and you're just going to watch them. We have yet to see how much of a problem this is going to be. These are fairly new products. I think people are not going to town on them the same way they do with cannabis. But again, it depends where they're being distributed, and they're still fairly new. So just watch out for the mushroom chocolate. The last one I wanted to talk about was something called gas station heroin that you've probably seen in the news. And this is something called tianeptine. It's sold under the brand name Zaza or Neptune. And I have a confession to make. I really wanted to get this, and I couldn't get it in any of these places. I went around Las Vegas and asked about it. None of the shops stocked it. Some of the manufacturers, people selling it, did tell me to go online. So people have been asking for it. Maybe they've sold it in the past and taken it off their shelves. I was directed to several websites where it was sold for about $50 for a bottle of 15 to 20 pills, plus or minus postage. You could pay by a credit card, Bitcoin, PayPal, and a few other things. So I don't have this one to show you, but I do want to talk about it because it is coming up in the news and in some of the medical literature. So tianeptine is a tricyclic. It looks pretty similar to imipramine. It's got those 3 rings, and it's actually used as a medicine in several other parts of the world, Europe, South America, and Asia, where it goes under the names of Stabilon or Coaxil. It was never approved for medical use in the USA, but it is a medication in other places. And it's existed since the 80s. It's an old drug. No one really knew how it worked. They thought it maybe had something to do with glutaminergic transmission. But then in 2014, somebody decided that they're going to run some studies on it, and they found it's a mu receptor agonist. So it's actually an opioid, which makes sense, right? That's why people liked it so much, and that's why it was used for IBS, because it stopped people having diarrhea. People have got dependent on this. It behaves like an opioid withdrawal if they run out too quickly. There are case reports of people taking too much and needing naloxone to reverse it. So it's going to look probably more like an opioid than a tricyclic in overdose. The deaths that are reported is when it's used with other things rather than on its own. So it's going to be a polysubstance picture, which starts to paint us a picture of who is actually using this, right? It's people that like to use more than one drug, people who have developed a dependence on it. And interestingly, despite its structure, there aren't really any case reports or literature supporting that it causes TCA-like toxicity. So we're not seeing as wide complexes, the QRS widening, the dysrhythmias, the seizures, and all of those things, which is good in the sense that we don't see very sick patients with it. Opioid overdoses are easier to treat than tricyclic ones, but watch out for this stuff. If I get it, I'll let you know and update you. And I'd like to take any questions.
Manzi, that was awesome. I'm just thinking about like your journey through all of these gas stations looking for this stuff, and it really brought me a lot of joy. So I appreciate that and all of like the detail that went into putting this together. So I think we are in a good spot to take a quick 2-minute rest. We're gonna catch up on our schedule here. We're gonna kick it off in about 2 or 3 minutes. So take a bio break if you guys need to, and we'll be right back with the next speaker. All right, let's bring it in. Bring it back. We're going to keep the party rolling here. So next, we're going to hear from Dr. Andrea Wolf, Assistant Professor of Emergency Medicine at Creighton University, East Valley, Arizona. She will be presenting Perk Up with Years, an evidence-based approach to low to moderate risk PE.
Good morning. Let me see if I can get my screen to share here. So can you all see my screen right now?
Yep, looks good.
Okay, let me try this. Okay. All right. Thank you so much for having me here. I'm totally pumped to be part of the first Four Corners education event, and I'm excited to be talking about PE today. We spend a ton of time worrying about PE in the emergency department, but the funny thing is it's not the sick ones that are hard to manage, right? We know what to do with those patients. It's actually the less sick patients that tend to cause the most confusion when it comes to the workup. With that in mind, our goals for this talk today are to discuss why we need an evidence-based approach to PE evaluation and to develop an algorithmic approach to patient evaluation that incorporates the recent literature. And then we're going to apply an evidence-based strategy to risk stratify our low to moderate risk patients. So much to my husband's continual disappointment, I have no financial conflicts of interest, but I thought I would share one of my fearsome apex predators with you today. So the first question is always, why does this topic matter? Why don't we just scan everybody with a chest, right? It would certainly simplify things. In the interest of time, I'm just going to get straight to the point. CT angio has a 5% false positive rate for PE. That's way higher than I thought it was, but what this means is that 1 in 20 of the patients that we investigate for PE with CT angio is actually a false positive. And this is a big deal because anticoagulation is not a benign intervention. There are real harms associated with its use. And this is why we have to be careful and critical about who we investigate. Because anticoagulating false positives has no potential for benefit, but there is real potential for harm. Anytime we evaluate patients, we follow a pretty standard diagnostic process, and this is true of PE as well. Once you decide that your patient could potentially have a PE, the first step is to risk stratify that patient, meaning you're deciding on their pre-test probability. This is what determines how you move forward with your evaluation, because based on that pretest probability, you will decide whether to apply a clinical decision instrument, whether to go straight to diagnostic testing, and that is what you will use to move that patient to an either higher or lower post-test probability, or what we commonly think of as ruling in or ruling out disease. Before we get into the specifics, I do want to make sure everyone listening is clear on the difference between a risk stratification tool and a clinical decision instrument, because they're not the same thing and they are not interchangeable. Risk stratification tools are things like the Wells score and the Geneva score, and they do exactly that. They are validated to provide an assessment of pretest probability, but they are not validated to actually rule in or rule out a diagnosis. By contrast, clinical decision instruments are designed and validated to actually exclude a diagnosis such that no further testing is required. And some examples of this are things like the Nexus C-spine criteria or the P-Carn head injury rule. Risk stratification has to happen before you can deploy a clinical decision instrument, because you have to know if that patient is appropriate for that clinical decision instrument. And although this is a fine distinction, it's important to make sure that you are applying these correctly to your patients. The most common risk stratification scores for PE are probably the Wells and the Geneva score. And this is one of those things that is almost like a fight me statement, but I don't dig Wells. And the reason I don't dig Wells is because of this. This second criteria point, which is one of the most heavily weighted, is asking you to make a judgment call about whether or not you think PE is the most likely diagnosis. The whole point of a scoring system should be to be objective and not ask you to make a subjective call. And unfortunately, this is asking you to use your gestalt, which new clinicians and a lot of our learners just haven't had time to develop yet. Considering that this one criterion alone is enough to move you from a low risk to a moderate risk category, I feel like that's just too big of a judgment call to make. So I encourage my learners to use the revised Geneva score because it doesn't have that subjective component. But at the end of the day, they are both validated, and I encourage you to consider adopting one of these, as data have shown over and over that we as clinicians have a tendency to overestimate the risk of PE in our patients. So now that you've risk stratified your patient, it's time to move on to the next step. The majority of the patients that we see in the emergency department that we're considering for PE will fall into the low or moderate risk categories. And for the patients that risk stratify into a low risk cohort, the next step in their evaluation is to apply validated clinical decision instrument. I'm sure everyone on this call has probably heard of the PERC rule. And the PERC rule has been extensively validated, and it identifies a group of patients at low enough risk for PE that no further workup is necessary. As with any clinical decision instrument, you do have to apply it to the correct population, and this rule was developed for patients with a pretest probability of 15% or less. If your patient meets the PERC criteria, then your patient has a pretest probability of less than 2% for PE. Now, we just said earlier that a CT angiogram has a false positive rate of 5%, right? If you take a patient with a pretest probability of less than 2% and apply a test with a false positive rate of 5%, you are more likely to end up with a false positive than a true positive, meaning you're actually more likely to harm your patient than help them by doing further investigation. The other clinical decision instrument that's come into vogue since it was published in 2017 is the Years algorithm. This has also been extensively validated, so you should feel comfortable incorporating this into your practice. They chose these three elements from the Wells score that have the highest predictive value and added D-dimer testing for all patients. If your patient had none of these, sorry, my cat is singing, if you have none of the Years criteria, you can double your D-dimer threshold to 1,000. But if your patient has one or more of these, you just keep your D-dimer threshold at 500. In doing so, they were able to safely exclude PE and saw an absolute reduction of 14% in the need for CT imaging. And the only downside to the Years algorithm is that it includes the same criterion that I'm a little salty about from the Wells score, and it also mandates D-dimer testing in all patients. So which should you use? They are both widely validated, they're both appropriate. My preference is to use PERC simply because it doesn't require any additional testing. But if I can't rule my patient out with PERC, then I will absolutely apply a Years algorithm to see if I can apply a higher D-dimer threshold in ruling out PE. There was actually a paper published about this in academic EM using this exact strategy, and they found that they could very safely exclude PE while minimizing the risks of radiation and contrast exposure in our low-risk patients. So at this point, we've risk stratified, we've excluded everyone we can with a PERC rule, and now the rest of our patients are going to need some kind of diagnostic testing. D-dimer is widely accepted as an appropriate strategy to rule out PE in low and moderate risk patients. D-dimer is a product of fibrin degradation, so it can indicate the presence of thrombus formation, but the downside is that it's not specific to PE. Patients with trauma, surgery, malignancies, and a whole host of other things can also have elevated D-dimer levels, so you just have to go into this being aware that D-dimer has relatively poor specificity, which means you're going to get some false positives. So who gets a D-dimer for PE? You're going to think about it in your low-risk patients who fail the PERC rule and in moderate-risk patients. It is not appropriate to get a D-dimer in high-risk patients, and here's why. D-dimer has a negative likelihood ratio of 0.1, which is actually really good. But if you have a high pre-test probability, it still just can't get you to a low enough post-test probability to rule out PE. So if you have a high-risk patient, those patients just need to go straight to CT imaging. Unfortunately, D-dimer isn't really all that helpful in our post-op patients either, particularly those who've had intra-abdominal, intrathoracic, or major orthopedic procedures, because in these patients, a D-dimer can be elevated for up to 5 to 6 weeks following their procedure. Another relatively recent advance in D-dimer is that we can actually age adjust our D-dimer. As we age, there is an age-dependent increase in D-dimer levels, and since this population is at greater risk for things like contrast nephropathy and extravasation injury, if we can use an elevated D-dimer threshold, that's super helpful. Fortunately, the formula only requires basic arithmetic still, so if you just take the patient's age times 10, and that's your age-adjusted D-dimer threshold. The original paper from JAMA has validated this, and it has since been incorporated into guidelines from multiple clinical societies, so you can feel comfortable incorporating this into your practice. And this, of course, brings up the question of whether we can incorporate the age-adjusted D-dimer when we are applying the years algorithm to patients over 50. And fortunately, the answer is yes, we can. So for your patients over age 50 with 0 years criteria, you're still going to use that doubled cutoff of 1,000. But for patients over 50, instead of stopping your cutoff at 500, you can age adjust that D-dimer. And they found that when they did, they were able to safely exclude PE with no additional misses at 3 months, and they were able to reduce the need for CT imaging by 10%. All right, so let's bring it home. Here's our algorithm. We start by risk stratifying our patients with a Wells or a Geneva score. Your low-risk patients are going to come over here to the left side of the screen, where we're going to start them off with a PERC criteria. If they're PERC negative, PE is ruled out and you're done. Patients who fail the PERC rule are going to come join our moderate risk cohort. The moderate risk cohort are the folks that are going to get a D-dimer, and then they're going to go through the years algorithm, and that's going to include your low risks that failed the PERC rule. If they have 0 years criteria, you will go ahead and double your D-dimer threshold. If they have 1 or more years criteria, you will stick with the 500 cutoff unless they're over age 50, in which case you will age adjust their D-dimer. If these folks have a negative D-dimer with those modifications, PE is ruled out and you're done. If you fail this and your D-dimer is elevated, those folks will come join your high-risk folks that are going to go direct to CT imaging. And using this clinical strategy, we can safely exclude the diagnosis of PE in a lot more patients without having to punish them with radiation and CT imaging. So I know I went through that really quickly. I do have an expanded version of this talk that goes into a lot more detail about the evidence basis, etc. So I put my email address up here. Feel free to email me if you want more about this. But aside from that, I will happily take any questions that you have. Sorry about the feline interference. It never fails. As soon as you start talking, here they are.
Why don't you, in like, the minute that we have here, like what would be your like sales pitch to people who like when you talk about like yours criteria give you like that like skeptical like eyebrow raise when you tell them that we have to like 1,000 with our dimer when you're like working with residents or other people. If you could like really like, sell us on yours and like the evidence in like a 30-second sales pitch, what would it look like?
I think my 30-second sales pitch would be that it's been validated in multiple studies and they've reduced the need for CT imaging by over 15%. Done.
Cool. All right. Thank you, Dr. Wolf.
Thank you. Let me figure out how to stop sharing my screen.
All right. So we are gonna keep it going. Next up is going to be Briar Drummond. He's a clinical professor of emergency medicine from the University of Arizona College of Medicine Tucson University campus. He will present on climate health impacts on emergency medicine.
Cool. Thank you, Dylan. Everyone can hear me hopefully and see my screen there.
Looks great.
Sweet. All right. Yeah, I work at Tucson, Arizona, and my name's Brian. I'm a kind of a clinical guy, and I've shifted my career to focus on climate health. So for those that aren't familiar with this is basically how climate change is leading to health impacts. And we're going to talk today about how it's impacting us in the emergency room. So the two quick objectives, this is a huge topic, right? Climate health is huge. There's lots of intricacies, but I just want to expose you to this and talk about how it's increasing our disease burden. And then I also want to give you some solutions because climate change, if we get into those talks, people get, oh God, everything's burning down. This sucks. I want to give you something that you can take to the bedside tomorrow, some things you can do in your life and make a difference, right? Because that's what we're here for. Why do I do this? Why have I changed the focus of my career and the rest of my career is going to be on climate health? I do it for my family, right? I'm going to be fine. Most of us are going to be fine, but it's our kids and the next generations that are going to be feeling the impacts of this, as well as our patients. So, if we were taught in med school, which most of us were, that tobacco is bad, I think we would say, yes, that's a common thing. We know it causes strokes and heart disease and lung disease. But what if I told you that the consumption of fossil fuels is the cause of climate change, causes more death than tobacco, right? You're like, Brian, that's a sensationalized diagram. That's really nice and everything. But what if I presented it in a different format, in a journal, and we actually showed that pollution and the consumption of fossil fuels is causing more deaths prematurely than smoking or other tobacco products? I think then this is something we're missing in our education, right? This isn't taught in med school. This isn't taught in our residency programs. But this is just as important, if not more important, than helping patients decrease their tobacco usage or vaping or things like that. So why aren't we talking about this, right? So the consumption of fossil fuels is re-releasing carbon that's been stored underground for years. And so this is causing an increase in carbon dioxide levels. And if you look at carbon dioxide levels as they go up, temperatures go up. And this has been seen on our planet for millennia. So we're seeing rising temperatures, increased carbon dioxide levels. There's more extreme weather events happening, and then you have rising sea levels. And these four components are dictating all kinds of public health issues that are affecting our patients. So whether that's extreme heat or air pollution, mental health issues, food and water supply, lots of these systems in not just here in America in the Four Corners region, which we've seen tons of rising temperatures and extreme weather, but it's affecting patients worldwide. And so this is a global issue that we're seeing and trying to work on. So you can say, all right, Brian, I don't see CO2 levels every day, air pollution, I don't really check that. But what if we just take a couple things and we just say, okay, rising temperatures, extreme weather, and air quality. Do those affect the patients that we see or the disease burden or what we're seeing in the ER? Actually, yes. If you look at the bottom of this image, let's see, dehydration, heat stroke, heart disease, lung disease, mental health, trauma, allergies, vector-borne illnesses. All of those are our patients, right? That's bread and butter emergency medicine. All of these are being impacted by climate change. So what are we seeing with this? We're seeing increased heat burdens, right? We're seeing increased heart attacks as temperatures go up. We're seeing increase like people burning on the street, right? They're getting physical burns on themselves. Outside workers are having more kidney injuries and health effects, and they're coming to see us. An Australian study looked at this and said probably by 2030, the Australian healthcare system from climate change alone is going to have a 180% increase in cost. And so it's huge impacts that we're seeing in the emergency room. And this is all from climate change. So if you want to say well, it's not really applicable to us, I would say these are our bread and butter patients. We're seeing this every day. Any quick questions at this point on how climate change is leading to health effects that we're seeing in our patients? Sweet. All right, let's talk solutions, right? What can I do today or tomorrow? When we talk climate solutions, we're talking health solutions. So if we're healing the planet and working on things to draw down carbon dioxide levels in our atmosphere and cool our planet, we're helping people, right? It's just like asking someone to stop smoking. We are improving patients with these things. The cool part is if we clean our air or lower those temperatures, we're going to see health improvements immediately, right? It may take a long time for the carbon dioxide levels to come down, but during COVID, we saw people weren't consuming as many fossil fuels. And then guess what? Air's got clean. Decreased heart disease, decreased lung disease, decreased premature births. That was happening within a year. So immediately you can see impacts from working the climate issue. Now let's talk about how we can do this both systemically but individually as well. Sustainable healthcare is the model of looking at the healthcare industry and trying to clean up and not have us be as big of an impact we are. So if we want to say the healthcare industry in the United States is equal to the global carbon footprint of the United Kingdom. So it would rank 12th if it was a country by itself, just from what we're consuming. You're like, what are we really doing? Think about all the diesel consumed for like transportation for us both to work or ambulances. You can talk about consumables we use, the energy to run a hospital. All of this is impacting our carbon footprint, and that's leading to health outcomes for our patients. So what could we do in the emergency room? Let's think something very granular, right? How can we be more sustainable? First thing, think about switching from IV meds to oral meds. IV meds work faster sometimes, but like you can do quick things. Antibiotics. Does everyone need a dose of IV antibiotics for pneumonia or their pyelo before they go home? Nope. Oral antibiotics work. And the IDSA is actually switching to a lot more oral antibiotics in their guidelines and not necessarily having to do IV antibiotics. Another thing, Zofran, right? We give Zofran all the time. I'm sure you give it probably 10 to 20 times a shift. You're given 4 milligrams IV. There's studies to show that 8 ODT is equivalent to 4 IV. So say you just start doing your own randomized controlled trial. You run, ever give one 8 ODT, maybe it works on 4 to 5 patients. That's still an impact, right? You're decreasing your consumables that you're using, just in little changes like that. And when we talk about consumables, things that you want to think about is how can I use something that's more reusable than something that's a single-use throwaway things? What are you looking at that? Maybe I use a towel instead of a paper towel or a Chuck's pad to clean a patient up. Maybe I'm using a reusable laryngoscope blade instead of my disposable laryngoscope blade. Making those choices and helping within our healthcare system. Maybe we get reusable laceration trays instead of the crappy ones that we have to use that are disposable. So these are all things that we can change. Other things, just in terms of consumables, are gloves. All right, COVID, everyone started gloving up. I was bad. I used to like glove all the time, every patient's, everyone's nasty. I didn't want to touch them. And then I was like, oh, I can also not wash my hands because I put gloves on. So it's all good. Well, we actually are seeing that glove use is associated with poorer outcomes for our patients because we're not washing hands. We're not washing our hands before or after. We're not gelling in and out of the room. So gloves in our department, our smaller department here in Tucson, we spent $2.2 million on gloves just in the ER alone. So if we're looking to listen to someone's heart or listen to their lungs, push on their belly, you don't need gloves for that. Wash your hands. Patients like it, you'll like it, better for hygiene. Now, bloody mucus stuff, definitely wear gloves. If someone's nasty, put your gloves on. But I bet you could probably drop 1 out of 10 of your patient encounters and decrease your glove use. Another simple thing, Boxer's fractures. The Aussies did a great study, right? We used this. Everyone had to get an ulnar, gutter, splint. We were taught that's the way to do it. What about just buddy taping them? You actually get better return to work numbers with this. It's faster for you. It's less material, less impact on the environment. And if they have to go to a psych floor, absolutely they can go with a buddy tape where they may not be able to go with the splint. So just some things we can do in the ER and take away with that. What about breathing? We give all these inhalers, allergens are up, respiratory issues, wildfire smoke, all that's climate based. So what are we doing? We're giving inhalers to patients. But when we give inhalers, inhalers are actually not good for the environment either. They're worsening this, right? So those HFAs, inhalers, the albuterol, or maybe the inhaled steroid we're giving. Sometimes we're giving patients 2 inhalers, right? Rescue albuterol, and then we're giving them a long-acting steroid. What if we just combine it into 1 inhaler, right? There's good evidence to say we can actually use combo. So we could go back to a long-acting beta with a steroid, and that can be the breakthrough and their maintenance medication. So here, like 1 inhaler is better than 2 inhalers, right? Better for the climate. And if you switch it to a dry powdered inhaler, much less impact on climate as well. So I've actually like the last year, I've been prescribing this as my go-to. I use fluticasone salmeterol because here in Arizona, that's covered by most insurances. It's on generic, it's Advair generic, something that you guys could try tomorrow on your next shift. What about personally, right? So that's some sustainable healthcare, some personal decisions, 5 biggest impacts that you can make. And we're not going to talk, this is not a straws. We're not like saving plastic straws or anything like that. That's not a big impact. 5 big things. 1, generate your own power. Now, I know some of your residents are like, I don't have money, Brian. I'm like, no, that's fine. In the future, you have the opportunity to generate your own power. So generate your own power. Second would be fly less. So you see a car here packed. Flying has a huge carbon input. So if you can do road trips instead of flying, big choice that you can make. Obviously, if you're going to Europe, you can't drive there, but maybe around the country, you can do some driving. We've done trips for 4,000 to 5,000 miles at a time in our electric vehicle. So you can do long trips in this country. Third thing would be sustainable transportation. So walk, bike, or use an electric vehicle. Fourth, plant-based diet. So I'm not telling you not to have meat. This is a planetary diet is put out by the Lancet. So this is evidence-based. They have done some studies on this, but it actually improves, not just better for the planet, but if you think about it, someone with a plant-forward or plant-based diet actually improves diabetes, heart disease, lung disease, right? It improves all these factors that we're looking at already trying to work on. And then the 5th thing would be little carbon footprint. So I can't tell you to have kids or not have kids, but obviously I screwed up. You saw my 3 kids before, so 2 of us had 3, so we screwed up. But the other 4 I've worked on, and I think you can make those decisions yourself too. Other things, money matters, right? So if you want to do something, this is something you can do tomorrow. We all have investments, and you will have investments. You can use this QR code, look at fossilfreefunds.org. You can put in Fidelity, Schwab, Vanguard. You can put in any of your mutual funds and look and see what is the investment that they have in fossil fuels. I found I was invested in nuclear weapons with some of my investments, so I was like, I got to get out of this stuff. But it's a great breakdown that you can say, hey, I want to take money away. And you can say, Brian, I want to make money. Totally fine. Green investments last year actually did better than the S&P 500 by itself. And if you say, I want to just hit the S&P 500 when I do an index fund, that's okay. But 8 to 10% of index funds are fossil fuel-based investments. So if we as an emergency medicine community decided to take our $1 million, let's just say we all had $1 million at some point in our investments, and we move that out, that'd be $40 billion we're divesting from fossil fuels. That matters. And one last thing you can share with patients is this app. So this is PH app, right? So this is a public health app that they can get alerts on like air quality, weather, heat, and then links it to their public. Like here in Pima County, it links to the cooling centers. It links to where they can go for shelter if they had a storm, what flu outbreaks. So another simple thing, I'm offering this to patients to help educate them on air quality, heat effects, and put them out ahead of the climate change issues that they're going to face. Hopefully, it was a quick, brief overview showing that climate change is definitely impacting and making it an issue with our patients that we're seeing in the emergency room, and then offering some solutions both for you can do personally, but also as a sustainable emergency medicine practice. And please feel free to reach out to me at any point. I love talking about this stuff. So thank you.
All right. Thank you. Thank you, Dr. Drummond. We're gonna keep on moving here. And as always, as we kind of like move through here, I like really encourage people to reach out to the speakers like by email if you have any burning questions. Like they're a fountain of information, and I hope that you guys take that opportunity to tap into their knowledge base and expand your own. So we're going to move forward now. We're gonna have a combination pair here. Doctors Eva Wilson and Jessica Bates, Associate Program Director and Program Director, respectively, of the University of Arizona Tucson South Campus, will present together on tiny objects, big problems, pediatric congestions every EM physician must know.
All right, good morning, everyone. Let me start with a statement that each of us has said at least once on shift. They look fine. Every one of us has had that moment, right? The kid looks fine, the department is on fire, the history is vague, and you're deciding maybe it's 11 o'clock at night. Is this really worth waking somebody up for or arranging for a transfer? So today is about recognizing the rare times when they look fine is the most dangerous sentence in the room. Our goals today are intentionally practical. First, recognize the pediatric ingestions that actually matter. Second, apply evidence-based management without overcomplicating it. And third, know who can be observed and who needs an urgent intervention or transfer. And this is especially important for those of us who practice where you don't have pediatric GI, ENT, or surgery right down the hall.
So why it matters. For our pediatric patients, this is a really high risk to miss these type of presentations. So this is something that we want to make sure is high on your differential diagnosis and that you're always thinking about this. And the reason being is because in pediatric patients, 75% of foreign body ingestions and medication ingestions occur in pediatric patients under 5 years old. And so you're going to have very nonspecific symptoms. You're going to have a very vague history and a limited history because they can't really tell us. So the image that you're seeing here is actually from a 3-year-old patient that came into the emergency department after he was playing with his sister and fell and had neck pain. Initial presentation, got plain films, AP and lateral of the neck, and was discharged home, only to come back severely septic with a very bad HENT infection and had cross-sectional imaging where they found a small paintbrush that had lodged in the posterior pharynx when he fell when he was playing with his sister. So again, this should always be high on your differential diagnosis for pediatric patients that have nonspecific symptoms, even if they look well, because the history is often limited and it can lead to really serious adverse events. So what do we do in the emergency department? Obviously, we go back to the basics. We want to identify, is this pediatric patient sick or not sick, right? Are they tripoding? Are they tolerating their secretions? Is there stridor? And then assessing their breathing. Do they have equal breath sounds? Are they tachypnic, hypoxic? Get them on a monitor. Let's get vital signs. If their ABCs are okay and they're looking stable, then you want to try to get the most focused history that you can. Was this a witness event or unwitnessed? Was this a sudden onset in symptoms? Do you know if it was an object or medications? And if there's concern for medications, what available medications do you have in your house? And then what was the time of the ingestion?
Okay, so here's the classic case. A toddler comes in, they're drooling, the parents say they won't eat anything. They think that they saw the child ingest a quarter or a nickel. At this moment, your entire job is to answer one question. Is this a coin or is this a button battery? Because one of these can wait and the other absolutely cannot. Raise your hand if you feel like this X-ray is reassuring. And raise your hand if you are concerned. So button batteries cause an electrochemical injury. The electrical current causes a release of hydroxide ions, which causes injury to the tissue within minutes, and liquefactive necrosis can occur within 2 hours, so not a lot of time. Complications from button batteries in the esophagus include TE fistulas, strictures, and catastrophic hemorrhages from an aortoesophageal fistula. In terms of management, any button battery in the esophagus is an emergency, and removal within 2 hours is the goal. In a rural or community ED, this means rapid identification and immediate transfer coordination. Honey or sucralfate can be given to kids over 1 year of age if within 12 hours, but don't let this delay the definitive care. And remember, these kids need admission. Sometimes CT angiography is necessary because discovering an aortoesophageal fistula late can be a nightmare that none of us want. And then drawing your attention to the x-ray in the bottom right corner, you can see the homogeneous appearance of the coin versus that halo or double ring sign of the button battery. And if you're viewing that button battery in the lateral view, you'll see a step off side when you're viewing the edge of the button battery.
So the next case vignette, if you were in the emergency department and you had a 4-year-old come in with nonspecific abdominal pain, nausea, vomiting, and you obtained this KUB, what are you concerned about? So this is a KUB that is showing 2 magnets at different points in the intestinal system of a 4-year-old. And why is that concerning? So that's concerning because if these magnetize together, you can get bowel entrapment, necrosis, perforation, and then severe infection. So when we're talking about magnets, we have neodymium magnets, and these are about 5 to 10 times stronger than your average magnet. And these are really, really common in household items. So this is going to be in like jewelry clasps, in phone cases or Kindle cases, in toys. And so these are really common household items. And so as we talked about, if pediatric ingestions of just 1 is a little less concerning, but if you're having 2 at different times, they can magnetize together and entrap that bowel and be very high risk. So what do we want to do in this setting? If you're having signs that you have multiple ingested magnets, you do want to get a surgical consultation emergently and then also get the patient admitted. If there's only a single magnet, then you can have discussions with the consulting services on whether or not this patient needs to be admitted for serial observation, serial imaging versus outpatient follow-up or repeat imaging in 24 hours.
So let's quickly talk about some other foreign bodies that kiddos often ingest. Coins are still the most commonly ingested item, and they're usually benign unless they are stuck in the esophagus for more than 24 hours. Sharp or long objects are more about the size and the shape, not how comfortable the patient looks. So we really worry about objects that are greater than 2.5 centimeters wide and greater than 6 centimeters long. Water beads deserve respect. They expand and they obstruct. When you have a kiddo coming into the emergency department with a food bolus, this can often lead to the discovery of abnormal esophageal stricture. So even if you've got a kiddo that comes in and they have a piece of chicken that's stuck and it resolves in the emergency department, they really need to follow up with GI for further workup and given instructions on a diet change or thorough chewing of food, because this can unmask an underlying stricture. And then laundry pods are not just a foreign body. They are a toxic ingestion, and they can cause airway, pulmonary, and neurologic risk. So if you've got a kiddo who ingests a laundry pod, call poison control, provide some supportive care, and closely monitor their airway.
So we just had a quick slide here on One Pill Can Kill. We're not going to go over these all individually, but just something to be aware of is that when you have abnormal level of consciousness in a pediatric patient, you should always have this in your back of your mind as well, is medication ingestion in pediatric patients. These are some of the high-risk medications. So looking at the calcium channel blockers, beta blockers, sulfonylureas, insulin, and then analgesics are the other ones that we commonly see. So whether that's opiates, fentanyl, and then salicylates. We're not necessarily talking about just aspirin here, but that oil of wintergreen or maybe grandma's Bengay or Icy Hot, if they're trying that or tasting those creams, those also often have salicylates in them. And so making sure you're being aware of what could be available there.
Okay, so let's discuss our ED approach. Airway comes first always. You're going to want to use AP and lateral films to help you distinguish coins from batteries. Avoid barium studies. They complicate endoscopy and increase aspiration risk. And in our field, we're very conscientious about imaging pediatric patients. But if you have a high suspicion, this is not the time to worry about exposure to a small amount of radiation. You should really consider cross-sectional imaging based on your clinical suspicion.
So for system and transfer points, we just wanted to make a point that in these settings, about 25% of these transfers can be preventable. So if you don't have pediatrics, if you don't have GI available, this might be something to do telemedicine or standardized guidelines for, right? If the object is blunt and is already past the GE junction, they're asymptomatic and vital signs are fine, is this something that can just follow up with pediatrics or return to the emergency department in 24 hours, repeat KUB, et cetera? So just make sure that we are appropriately using our resources that are available and not over transferring these patients.
All right, so just a couple of quick pearls. If you remember nothing else, just remember these points. A button battery in the esophagus is a true emergency. Multiple magnets equals surgical admission. The size and shape matter more than the object's label. Laundry pods are a toxic ingestion, and never let a well-appearing child falsely reassure you. Pediatrics ingestions are dangerous, not because they're rare, but because the kid often looks normal. So the next time you hear yourself say, they look fine, pause, recognize early, act early, and escalate before the small objects become big consequences. Thank you so much for what you do. What you do truly matters, and we are happy to take any questions.
Hey guys, I just like spin off of the drive-in who was commenting on just like precautions and advice for family. Like, what kind of counseling do you do for, I guess, like child-proofing a house in like a world of all of this stuff, right? Especially given like all of the different things that can be ingested. What are your recommendations for family as they have a young kid at this point?
Yeah, that's a real challenge, isn't it? And you can't control where your child is at all times, and you stop over to grandma's house or a friend's house and you have very little control. So I think for parents, just giving reassurance that this is not your fault is important, but then counseling about keeping especially these high risk items up and out of the way, medications locked away in a safe, secure place, and then maybe just talking to grandma if grandma's going to be watching the kiddo about where is your purse, where are your medications, and making sure that those are up and out of the way where little hands can't grab at them.
And I think as Dr. Ivan kind of mentioned in the chat, even having a patient maybe coming in with a bead in the nose or in the ear, at that time frame, they're experimenting at home, they're having fun, they think this is interesting. And if your kid is prone to doing this, we're lucky this time it was just a bead in the nose, but you need to make sure that the rest of the house is childproof and prepared for that.
All right, let's end that here. We're going to move on to our next break. So take a second, recuperate, and we'll go from there. Thank you, guys. All right, let's bring it back in. We are almost through our lightning speakers here. We're getting closer and closer to our keynote speaker. So let's buckle up. Next up, we have Dr. Brendan Tarzia. He's core faculty with Creighton of Phoenix, Arizona Emergency Medicine, and he is presenting Burst or Bust, the evidence behind steroid use in the emergency department.
All right. Thank you, guys. Can you hear me? All right. Cool. Thank you. Thank you for having me. This is awesome. I'm Brendan Tarzia. I'm faculty, like Dr. Warr said, at Creighton of Phoenix, Maricopa in Phoenix, Arizona. We'll be talking about steroids today, evidence behind steroid use in the ED. No disclosures. So first off, for all you meatheads out here, we are not talking about these steroids. We are talking about these steroids. We're talking about corticosteroids. So the most common ones that we're using in the ED are prednisone, dexamethasone, methylprednisolone, hydrocortisone, and sometimes with ICU, we'll give fludrocortisone. And we love steroids in America, and really we love them globally, worldwide as well. In America, 7% of all Americans get steroids every year, so annually, which is a huge amount. which is why this is so important that we talk about it and we review the pharmacology and the risk of steroids in the ED. Then we're going to go through a rapid fire appraisal of all things steroids, evidence for the common uses in the ED. So first off, we have to know what are corticosteroids and what are we giving. So they are synthetic analogs of the stress hormones in our body. So they're synthetic analogs of the glucocorticoids and mineralocorticoids that come from our adrenal gland. So the function of cortisol, which is the main glucocorticoid in the body, is to help regulate stress. And it does a whole bunch of other things to do this as well. It increases blood glucose and helps influence metabolism. It increases cardiovascular tone and vascular resistance. It is involved with bone reabsorption and calcium homeostasis, and it has a significant immune modulation effect as well. And it's that anti-inflammatory and that immune suppression effect that really we're going for when we give corticosteroids like prednisone. So I'm not going to go through all of this, but really it does all of these things. It decreases all of the inflammation in the body when you give that corticosteroid, such as prednisone or methylprednisolone. And then quickly, the function of mineralocorticoids, the main one in our body being aldosterone, is to help regulate salt and water. And again, not to bore you too much, but just quickly, in the RAS system, which I know we all love from USMLE days, the aldosterone, the mineralocorticoid, is at the end of the RAS system and helps increase the sodium and water reabsorption in the body to help increase blood pressure. And so it's important to know that the steroids that we're giving, the corticosteroids, have different mineralocorticoid and glucocorticoid effects. So really the baseline is going to be hydrocortisone that has that 1-to-1 ratio of the mineralocorticoid and the glucocorticoid effect. And I know you can't read all this as a table, but if you just look at the red in dexamethasone, it's important just to note that it has no mineralocorticoid activity, and methylpred also has very low, but dexamethasone has significant glucocorticoid, so anti-inflammatory effects. Whereas fludrocortisone has significant mineralocorticoid effect and still has glucocorticoid effect. So whenever you're choosing the steroid to give, make sure you take this in mind as well. With all the immune suppression that we have and regulation, there's increased risks, long-term and short-term, to giving steroids. So starting off with the long-term, or the effects of taking steroids for a long time, so long-term use. And we all know these. So you have increased weight gain, or that Cushingoid appearance, or Cushing syndrome even maybe. 70% of patients on long-term steroids will have weight gain. About 12% will have fractures. There's also avascular necrosis and osteoporosis that occurs. There's 10% of patients on long-term steroids that have neuropsychiatric events, with depression being the most common one in long-term use. Then there's visual impairments with cataracts and glaucoma. About 12% on long-term use will have cataracts or develop cataracts. And then we can shut down our HPA axis and cause adrenal insufficiency through the negative feedback loop that we all know. You have increased risk of sepsis, as well as bacterial, viral, and fungal infections from long-term use. You have myopathies. You have cardiovascular disease that increase risk when you take long-term steroids. So hypertension increases, atrial fibrillation risk increases, diabetes, and heart failure. All of this increases from long-term risk or long-term use. So I know what you're thinking. I know what a lot of people are thinking, but we only give bursts in the ED, right? We only give the 5 days of steroids, so they can't be that bad. If they weren't, I wouldn't be talking about this. So what are the side effects of the short-term, the burst uses? So the literature that we're looking at has, it's a whole, some say burst is the 5 days, some say the short term is when it's like less than a week or less than 10 days. So the literature is a little bit all over the place on this, but for mainly all of this, we're talking about just the burst. So we know it causes hyperglycemia. So one of the most important things that you need to do is you need to talk to your patient if they have diabetes, or figure out if they have diabetes or pre-diabetes before you give them that burst of steroids. Because you don't want to kick that patient off into DKA, or maybe even like first time diabetes that is noted through DKA. You also have increased risk of the neuropsychiatric side effects within the first one week. Whereas, let me go back there. Whereas depression was an increased risk with long-term risk, the neuropsychiatric side effects in short-term risk are euphoria and hypomania. So we all know that some people say when they get steroids, they feel really good, right? They're jittery, they're energetic. That's likely some of the hypomania or the euphoria feeling that they're feeling. But we all have heard about the steroid-induced psychosis that patients may have as well, which can really be like life-altering. So we have to think about this whenever we're giving this as well. And they've looked back at especially insurance studies, and they've looked at from insurance registries on patients that filed a claim and did they have steroid use. And so a lot of patients had sepsis, VTE, including pulmonary embolism and deep vein thrombosis, GI bleed, heart failure, and increased fracture risk just in 30 days after getting one burst of a steroid. If the lawyers know about this, we have to know about this also, because this is obviously going to be, even if it is just an association and so low risk, it is a risk that that there is. In kids, they have side effects from burst as well. So they get hyperglycemia, sleep disturbance, pneumonia, sepsis, GI bleeds. This all increases with just a burst as well. And again, we have to start thinking about this, the potential side effects as well, and how it can harm our patients, but also harm ourselves as well. So there's been studies, and then they've looked at this in the court systems as well. And the most common thing that's filed against physicians or practitioners in general is medical negligence for not talking to the patient about the possible side effects. And when we look at the possible side effects that have increased risk of having a lawsuit, it's avascular necrosis, it's the psychiatric side effects, and it's the visual impairment, including the cataracts as well, that increases the risk of medical negligence being filed. And lastly, we need to just understand the dose that we're giving. So we don't want to overdose these patients with steroids. So if your patient is okay getting 60 milligrams of prednisone, which is usually the high that we usually give, if you put this into the steroid calculator, that 60 milligrams of prednisone is about 48 milligrams of methylprednisolone, solumedrol. So if you wanted to give 60 milligrams of prednisone, but you're like, oh, you know what, let me switch it to methylprednisolone, then you probably should switch it to 48 of methylprednisolone and not give that 125 milligram vial. Because if you do, then that 125 milligram vial is giving the equivalent of 156 of prednisone. So ask yourself, do you want that patient to have 156 of prednisone at that time? So just have this in mind. And with that, we're going to go through a whole bunch of reasons for corticosteroids in the ED. And this is just going to be really just rapid fire as we go. I can't go through all of this. I'm not going to say dosing as much as just if the evidence is for, against, or wishy-washy for it. And I'll give you all my resources. If you have questions, let me know at the end. So it's flu season, it's cold season, COVID's coming back, everyone's got a cough, everyone has bronchitis, right? What is the evidence for it? And we all know this. There's really no evidence to ever give steroid burst for cough or bronchitis in ED, or in general, lower respiratory tract infections. This was actually a randomized control study that was done in 2017 in JAMA that showed that there was no improvement versus placebo at 5 days in a week. Steroids are out for cough and bronchitis. Do not give. They get a thumbs down. How about pharyngitis? Everyone has a sore throat as well. Everyone has sore throat with flu. There's a lot of studies looked at this as well. Some are the systematic review. There's actually a randomized control trial in 2017 as well. And the trend is at 24 hours and 48 hours, there is a slight improvement actually in pain that the patient does have with corticosteroids, but there's no difference in recurrence rates of having that pharyngitis or decreased time off school or work. And in that RCT that they did in 2017, there was no improvement really in the pain at 24 hours, but there was slightly at the 48 hours. So I'm going to give this a maybe. There's some evidence that you can give it, but you need to have that shared decision making with the patient, and you need to understand the risks as well. If it's severe sore throat, they really need it, then okay, maybe because there's some evidence that you could give it. How about if that sore throat turns into a peritonsillar abscess? We've looked at this as well, and it's pretty similar to the sore throat without the peritonsillar abscess, that maybe there's a decrease in pain at about 24 hours. And maybe, and this was not statistically significant, but there was an increase of returning to normal activity at 24 hours and being able to eat and drink normally at that time as well. And then after 24 hours, there was no really improvement in symptoms. So again, I'm going to give this, if they're severe PTA, then, and they really want that improvement and it's 24 hours, you need that, then okay. But have that discussion with them. If their glucose is out of control, they're diabetic, Probably do not do that without a good shared decision making with that patient. Moving on to lower back pain, one of the most common things we see in the ED. We're going to split this up into radicular back pain and non-radicular. So when we're looking at non-radicular, so non-radiating back pain, this is a Cochrane review that looked at both, and it showed that non-radicular back pain was actually associated with slightly worse short-term pain, but maybe slightly better function, but that better function was not statistically significant. So they do not recommend giving steroids for non-radicular back pain. There's been multiple other studies that confirm this as well. For non-radiating back pain, we should not be giving steroids. But then we get into radicular or radiating back pain. And then for this, there maybe is some benefit to giving it if that is shooting lower back pain. But this is one of my favorite lines from a study in general. So it says for radicular back pain, systemic corticosteroids probably slightly decrease pain versus placebo. So if that's not hedging, I don't know what is. And then there's no improvement in quality of life or decreased surgical need, especially when it's a hernia that's causing it. I'm probably going to say based off of that one, you can have a discussion with a patient if you want to give it or not. And there has been a randomized controls trial that came out a couple of years ago that showed similar. It was dexamethasone versus placebo, and maybe there's a little decrease, 2 out of 10 around in the visual acuity pain scale at 24 hours. But after the 24 hours, there really was no improvement in pain or function at the 6 weeks. Like I said, if pain is radicular, radiating, and severe, you can think about it. But again, I'm not going to give it every time, and I don't think that we should be giving it every time. How about asthma and COPD? So this one, finally, we have one that has good evidence for it. In moderate, severe exacerbations, we should be giving steroids. Especially within the first 1 hour, they reduce the need for hospital admission. So this is important to give it early. Don't not give the bronchodilators like albuterol, but you should be giving it if they're moderate or severe within the first 1 hour. And it has been shown when you give the corticosteroids, it decreases the rates of relapse, hospital length of stay, and in COPD, but not asthma, it's been shown to decrease the need for invasive and non-invasive ventilation. The reason why it really hasn't been shown in asthma is the studies just haven't been done, but it probably would if we had that study. And when I looked at steroids, IV versus PO, it's basically all the same. You can give whatever you want, dexamethasone, methylprednisolone, but what you should do is probably dose it 40 to 60 milligrams of prednisone or the equivalent. So again, maybe that 125 of solumedrol is too high, and you should have that discussion with pharmacy. Probably not going to change your management for that, but just know that we're probably giving too high doses of the methylprednisolone when we give that. Moving on to anaphylaxis. So we really give anaphylaxis, we give steroids and anaphylaxis to decrease the rates of recurrence or the biphasic reaction, but this just hasn't been shown to improve it. So we probably do not need to be giving it every time that someone has anaphylaxis, but in this guideline stated, basically, you're probably not going to stop giving it. So just make sure that you don't delay giving the epinephrine when you want to give that corticosteroid as well. Herpes zoster, there's no evidence for giving it for post-herpetic neuralgia or just for the zoster itself. But if it goes to the ear and you have Ramsay-Hunt or you have facial nerve palsy, then maybe there is some evidence that you should give it. But again, it's really non-conclusive evidence. But the guidelines still say we probably should give it. And so I would say not good evidence, but give it possibly. But if it's Bell's palsy, this is really where you have that good evidence to give it. And there's a Cochrane review study that showed there was a number needed to treat of 10 to avoid the incomplete facial nerve palsy. So you should give it then. And finally, just whipping through these, severe pneumonia. This guideline changed from the Cape Cod trial in 2023. And so the critical care societies are now recommending hydrocortisone 200 milligrams per day in severe pneumonia. So we should probably get 50 milligrams IV in the ED. It will decrease 28-day mortality when we give it. And just look at the guidelines for what is severe pneumonia. If you're going to admit them to the ICU, they're intubated on pressors, then you should give it. And again, COVID pneumonia, 6 milligrams dexamethasone with a recovery trial to give it, but do not give it in flu pneumonia because there's some old data that shows it actually increases mortality. But again, this is pretty bad evidence. And then finally, septic shock. The critical care societies do recommend giving it hydrocortisone 200 milligrams per day to decrease long-term and short-term mortality. This is new from 2024, the SCCM guidelines. And they say that they recommend hydrocortisone. They say you could give fludrocortisone, because there maybe is some evidence that that would improve as well in 90-day mortality. But again, that's not in the guidelines just yet. So have that discussion for giving fludrocortisone plus hydrocortisone with your ICU physicians. And then I know I'm running out. So meningitis, bacterial meningitis, there is improvement in decreased mortality and in hearing impairment. So give it with antibiotics or before. Finally, just want to go through this one more time. Good evidence for asthma, Bell's palsy, pneumonia, septic shock, and bacterial meningitis. Not good for cough, radicular back pain, herpes zoster, and flu. Everything else is in between. Know your risks, know your patients, and do your reading. And let me know if you have any questions. I appreciate it. Sorry for running over.
Just real quickly, somebody was just talking, just like threw out like acute croup in the chat.
Yeah, there is some evidence for giving. There is evidence for giving croup in kids.
Cool.
Yeah.
All right. Thank you, Dr. Tarzia.
I guess.
Yeah, that was awesome. So we are going to keep the train moving. One more lightning talk before we get to our keynote speaker. This is going to be Dr. Brian Merritt. He's a medical education fellow from the University of Utah Emergency Medicine Program. He is going to be talking about navigating the shock state, understanding etiologies, and early management.
All right. Good morning. I think it's still morning for most of us. Are you guys able to see this in presenter mode? I've never actually done presenter mode on Zoom. Whether or not. Are you seeing my slides at least? Or are
I
you
see
seeing
slides,
the whole
but
thing?
we see notes too. You could share part of your screen. If you do like part share, you can drag the like green square over your PowerPoint slide, and that should capture it.
Too complicated. We'll just do this. This will be fine. So yeah, I'm Brian. I'm one of the education fellows. So we're going to talk about shock, and the real foundation of this lecture was some of my initial struggles as a resident and figuring out how to assess and manage patients primarily in undifferentiated shock initially. And I'll go through some cases to jog your memory of patients that you see, and we'll get into shock and some management. So we're going to talk about classifications of shock, an initial approach, and then how to apply your clinical findings to guide your resuscitation. So just to put you in the right frame of mind here, we have a few patients we're not going to spend a ton of time on, but 68-year-old male, history of coronary artery disease, hypertension, comes in with chest pain, dyspnea. On arrival, he's hypotensive, tachycardic, he's hypoxic, you note diffuse rouse, he has respiratory distress, and he has cool skin. You have a 53-year-old female, history of renal transplant, presenting with fever, weakness, cough. Again, she's hypotensive, tachycardic, she's febrile. You note some rhonchi in the right lower lobe, but she has warm and dry skin. And then last, you have a 56-year-old male, history of ESRD on dialysis, presents with chest tightness, dyspnea. Similarly, hypotensive, tachycardic, slightly hypoxic on arrival. And on exam, you note distant heart sounds, JVD, and lungs are clear, right? So those are patients that you can see rolling into the department. These are things we see all the time. And you have a frame to guide your initial resuscitation. But one of the things that I noticed that I tended to struggle with early in residency was patients that are more like this. So you have a 66-year-old female brought in by EMS. Family hasn't heard from her in a few days. She lives alone. She's confused. She's never been to your hospital before. You don't have any records. You're able to get a hold of family, and they think she might have high blood pressure, but they're not really sure. They don't really talk to her all that much. And she's hypotensive, tachycardic, and slightly hypoxic. So where do we start with this patient? We have no information. They're not sick enough that we're doing ACLS and we have a set algorithm, but they're a little too sick where we can really sit back, take our time, and do a thorough history. And so the point of this lecture is to really provide an initial framework of where to start and how to manage these patients initially. So just to lead with what is shock and what are we actually really talking about here? So it's the inadequate delivery of oxygen to the cellular level. And it involves a demand mismatch, usually from insufficient tissue perfusion. But I want to add that shock doesn't require hypotension, and hypotension doesn't mean that they aren't necessarily in shock. They can be two exclusive things. Oftentimes they are very correlated, but you can't have one without the other. Shock is bad. It can progress pretty quickly to worsening organ dysfunction and ultimately death if not caught and managed early. So similarly, other abnormal vital signs are very common in patients with shock, but they're not required. Something that we have found that is a little bit more of a reliable marker is your shock index, where a shock index greater than 0.8 in medical, shock index greater than 1 in trauma patients is a better predictor of post-intubation hypotension, cardiac arrest, and can get you clued in a little bit better to these patients that may or may not be in shock. We're not going to go through all of these underlying etiologies, but just to refresh your categories of shocks, we have distributive, which we see quite often with our septic shock, anaphylaxis, neurogenic as well. Obstructive, where we have tamponade, tension pneumothorax, massive PE. Hypovolemic, which can be hemorrhagic from trauma or atraumatic in the setting of GI bleed or other pathologies. And then non-traumatic volume loss as well. And lastly, cardiogenic, where we have acute MI, decompensated heart failure, or valvulopathies, our critical dysrhythmias. So those are the buckets that we get to play with here. Where do we start with this patient? This is one that you are going to evaluate and act pretty simultaneously, right? This is the one, and I feel like this is always the patient where they come in and they start telling you about their ankle injury in 1991, and this is where you're going to interrupt pretty quick and get to the point. So one thing that I have found that has helped is asking their one or two most concerning symptoms that bring them in today, and then using that to piggyback and asking more focused questions. This is one where I tend to like to really drive the history taking, answering more kind of simple questions for them to answer rather than leaving it more open-ended that we may in some other patients. We're going to do a focused physical exam, obviously, but also including mentation and skin perfusion, things that I think that we do, but we don't necessarily do very often. And we're going to grab our bedside ultrasound. This is not meant to be an ultrasound lecture, but I am a big advocate for bedside ultrasound in this situation. We're going to talk about the rush exam that I think a lot of you probably are familiar with, but something that I wasn't initially familiar with when I started residency and had these initial struggles. So what is the rush exam and how do we do it? So this is the rapid ultrasonography in shock and hypotension. And a way that you can remember what this entails is when a patient has a low map, think high map. High map is the mnemonic that we have for this. So we're going to look at the heart. And ideally, if you can get it done in 2 views with your parasternal long and your apical 4, looking for signs of right heart strain, tamponade, significantly reduced ejection fraction, things like that. We're going to look at our IVC, look at its diameter, if its collapsibility, Morrison's pouch, just looking mostly at the right upper quadrant where we're most likely to find free fluid within the abdomen. But if you're concerned about intra-abdominal pathology or intra-abdominal bleeding, certainly you can finish the remainder of the FAST exam looking at the left upper quadrant and the pelvis as well. Aorta, looking certainly for our dissections, for our aneurysms, and then pulmonary, looking for a few different things as well. Pneumothorax, a massive effusion, B lines that can suggest cardiogenic shock, things like that. So this is where we're going to start. And what do we do about their vital signs? So we're going to hang a liter of fluids, right? Because that's what we do to fix hypotension. I feel like some of these patients just bring their own liters. Like by the time I'm in there, they're already like halfway through a liter somehow. I don't know. But a lot of the times, yes, that is going to be the right answer. But there are some of these situations where we want to be cautious in our volume resuscitation or avoid it initially. Or cases of suspected cardiogenic shock that may not have pulmonary edema yet. Maybe we can give them a small bolus or kind of a trial and see how they do. Our cases of massive PE, we aren't going to want to over resuscitate them as well. And then certainly we're going to want to avoid initial fluid resuscitation in our cardiogenic shock patients, especially with pulmonary edema. And there can be an in-between, right? It doesn't have to be a full liter on a pressure bag all the time. We can give smaller boluses, 250 to 500 cc's, and see how they're doing. We can use a passive leg raise to assess their responsiveness, and that is going to mimic really a 350 to 500 cc fluid bolus that really is intrinsic. And if they don't do well, we lay them back down and all is forgiven. But when we're doing that, we're going to monitor their cardiac output on POCUS ideally to really assess their fluid responsiveness. And while we're talking about fluids, I would be remiss if I didn't throw in some recent literature and evidence-based practice here as well. So the SMART trial basically advocated for balanced crystalloids like lactated ringers, as opposed to saline in patients with critical illness. They had improved mortality and less renal replacement therapy. Other things to manage in these patients. I know we're going to be fixated on the blood pressure and their heart rate, but we want to certainly optimize our oxygenation, reach for positive pressure early, I would say, in some of these patients. Increased work of breathing can generate quite a bit of increased metabolic demand, worsening that demand mismatch and worsening the shock. And then other things to keep in mind too are fever, pain, agitation, seizure, other things that can increase the metabolic demands in that patient. And then in cases of severe anemia, typically a restricted transfusion strategy is going to be appropriate. Obviously, if they're hemorrhaging, then we're going to resuscitate with blood, or if they have known significant coronary vascular disease or ongoing myocardial injury, then we're going to have kind of a higher transfusion protocol. But in most cases, we can use a restrictive strategy. And then our vasoactive medications. Your initial vasopressor of choice is going to vary based on your initial pathology. Some are going, there isn't necessarily a right or wrong answer a lot of times. I think similarly to probably saline and lactated ringers, some of us just have our go-tos. I would say a large majority of the time, in my opinion, norepinephrine is going to be first line vasopressor that I'm going to reach for. And then your second and third line, depending if you need to add additional agents or you need other pharmacologic needs, that's going to be dictated on the pathology. So in your cases of your decompensated cardiogenic shock, if you do your bedside ultrasound and your ejection fraction is less than 10 and they are still decompensated, then maybe you need some increased inotropy and you reach for dobutamine or your epinephrine. In your septic shock that's refractory to norepinephrine, or you just have increasing dosing, vasopressin or epinephrine again. Certainly in your cases of anaphylactic shock, we're going to reach for epinephrine first. And there is evidence, and I have some more evidence on the next page, but to support the use of early vasopressors in septic shock, especially if you really get the hunch that this patient is going to be really sick, I would encourage you, especially in your septic shock patients, to reach for vasopressors early while you're still volume resuscitating these patients as well. And a limited role in your true hypovolemia and your non-PE obstructive shock, right? So if you have a tension pneumothorax, norepinephrine isn't really going to help you a whole lot. Fixing the underlying cause is going to be your best bet in those situations. Just some recent literature surrounding shock and critical illness. So the sensor trial is one that I mentioned that showed improved shock control with use of early norepinephrine in septic shock patients. The Andromeda Shock 2 trial recently came out, which is the big brother of Andromeda Shock 1, that really highlighted the use of a personalized resuscitation strategy targeting capillary refill that was superior to usual care in early septic shock. And Andromeda Shock 1 was looking again at capillary refill compared to lactate clearance. It wasn't found to be statistically significant, but they felt it was underpowered, so expanded it, and that's what led to the Andromeda Shock 2 trial. Everdac is one that came out pretty recently as well. Not necessarily management of shock, but showed that blood pressure management or monitoring with non-invasive blood pressure maneuvers is non-inferior to arterial catheterization. Not to say that arterial lines are bad, but that you can manage these patients in a pinch if you need to, certainly with your non-invasive blood pressure cuff. And then lastly, really not related to shock, but just one that I think is a good read and something that would certainly be a good journal club or just worth your time is the RSI trial, one that came out probably about a month ago now, that looked again at the debate of etomidate versus ketamine for RSI. And this one was randomized, prospective, actually showed that etomidate may be better than ketamine in a lot of situations. Not choosing sides, just again, additional evidence just as a good read. So to recap, early recognition of shock is crucial. They can decompensate and progress quite quickly. Rapid history and assessment, ideally in synergy, is going to really facilitate your workup. Having a framework of when these patients arrive, knowing what to jump to and how to get to your assessment and management is going to help. Use POCUS, and I will add that you're allowed to reevaluate patients and ultrasound and reassess how they're doing, right? If you give a small volume bolus, reassess. I feel like I would routinely just tend to want to just continue volume resuscitating our hypotensive septic shock patients and not want to go to the bedside because you're busy. But this is probably one of your sickest patients that you're managing. So you're allowed to reevaluate patients. Fluids are often going to be the answer, but consider early vasopressors. And I will end with one of my attendings told me once that patients don't read Tintinellis or Rosens. And what I mean by that is they aren't necessarily going to be in one bucket of shock etiologies. So patients can have a lot of underlying things going on that complicate their progression, their management, their response to your interventions. For example, your cardiogenic shock patient might just have gut malperfusion now and has translocation through their gut mucosa, and now they have a SIRS inflammatory response and have some hypovolemia or some vasodilation as well. They don't always necessarily fit into one bucket. It's not one of your step exams or a textbook. Using some of these strategies to assess and reassess their response is going to help in your resuscitation. Some references and my emails if you have any questions.
Sweet. Dr. Merritt, appreciate you, and the always appropriate reminder that the patient does not read the textbook, which frustrates, I think, everybody half the time.
Yeah.
Definitely lends some excitement to emergency medicine. So we have a couple minutes. Let's take a 2-3 minute break real quick. Take a deep breath. Up next, keynote speaker time. So let's give a rounding applause and welcome to our keynote speaker, Dr. Vicki Norton. She's president-elect of AAEM and hails from Florida Atlantic University's College of Medicine. She is a resounding advocate for physician-led care and will be speaking to us today on the state of emergency medicine and business of. The floor is yours.
Great. Thank you. Good morning, everybody. And thank you so much for having me. And thank you to Dr. Warr for all the hard work you've done and organizing this amazing conference and the kickoff to the new state or regional chapter for the Four Corners Plus. So I'm excited to be here and talk to you guys about the state of emergency medicine. I know that originally I was going to maybe talk more on the business side of things, but I just feel like in the current environment that it's really important to maybe talk about all the things that are affecting emergency medicine. And so I wanted to give a broader picture of all the things that are affecting our practice and talk to you about it. And I'm sorry if some of my slides are going to be a little bit cut off because I'm sharing part of my screen so I can see my notes. So I have no disclosures. And our objectives today, we're going to be talking about some updates from AAEM, our national advocacy priorities. We're going to talk a little bit about the political landscape that we find ourselves in and talk about sustainability and the business side of things in emergency medicine. And then I wanted to go local, and we'll talk about your individual states a little bit and give some background on the political landscape there and talk about state level advocacy and why that's important, and then review what you as an individual could do to help. So this is our mission statement for AAEM, newly rolled out this past year. We just pared it down and made it more focused on what our true mission and why we were founded. And that's that we fight for high quality patient care delivered by board certified emergency physicians, and we champion a fair and equitable workplace for emergency physicians. So that's really why we were founded back in 1993. I don't know if a lot of people know the history of AAEM, but this was our original mission statement. Our current vision statement is our original mission statement, which was like 30 paragraphs long. But it really was born out of what we at the time saw as a crisis. And there was a book published under a pseudonym, The Phoenix, called The Rape of Emergency Medicine, where we were seeing that business interests were taking advantage of emergency physicians and enriching themselves off the backs of emergency physicians. And that we saw that nobody was speaking up against this. And then at the same time, we saw an issue with physicians being placed in emergency departments that maybe didn't have the correct training or that had questionable histories with substance problems and malpractice issues, that we wanted to really advocate for strong training and education of physicians. And so part of that was saying that we should be board certified to work in an emergency room. So we've been really working on advancing this mission, advancing education. We revamped our CME Online. We launched our Business of Emergency Medicine curriculum, and that's really to teach physicians the business concepts in medicine and specifically in emergency medicine, because most physicians do not understand how they are paid or why they are paid or see what is billed and collected in their name. That's very important, and I encourage you all to check that out, because this talk will not be going into the details of that, because I thought that would be a little too boring. And also, like I said, I wanted to give a more wide lens of what's going on. So our strategic plan that we're going to be implementing for the next year, we're still focusing on advocacy and education, but I wanted to point out that we're also looking at innovation. We want to be at the forefront of examining AI in healthcare and seeing how we can incorporate AI into our practice of emergency medicine. And we've been shaping this conversation in emergency medicine, talking about the corporate influence in medicine and fair workplace for physicians. We've been featured in prominent publications like the New York Times, the Wall Street Journal, and we really talk about physician autonomy and how we can combat corporate influence over our decision-making. So part of that, we've been working through our advocacy. We've met with the FTC. We've spoken at different panel discussions with Georgetown Center for Health Insurance Reform. We've presented at the boarding summit with HHS and ARC. We've signed on to advocacy letters and partnered with other organizations like the AMA. And we actually just got 3 seats for delegates in the AMA. So expanding our influence in the House of Medicine. So what are our main advocacy priorities? And these are things that if you're a resident or a student listening to this talk, I really want you to take away these 3 concepts from the talk, because this is what is massively affecting emergency medicine and the physicians and how they're working. So due process for physicians, non-competes in physician contracts, and the corporate practice of medicine. So let's get into each of these. And Tyrone got cut off. So this is, I'm dating myself with this Chappelle joke. Tyrone wants his due process. So let's talk about due process. Now, many of you may not realize that you're actually supposed to be guaranteed due process rights as a member of medical staff. And that's part of conditions of participation in Medicare and Medicaid that every hospital signs on to when they take Medicare and Medicaid dollars. And that was instituted many, many years ago in order to protect physicians when they're advocating for the right thing, to give them due process. And we're not talking about the Fifth Amendment due process. We're talking specifically about the due process that you should be afforded when you're working for a hospital, so that you can't just be terminated because you looked at the CEO cross-eyed. So in this case, when they do terminate you without any due process, you can sue for wrongful termination. There's avenues that you can take to work against this. But what is happening in emergency medicine is a majority of emergency physicians work for third-party contractors. So you're not working directly for the hospital. You're not working for a university. A lot of times you are working for a corporate group that has a contract to staff the hospital. And when you sign your employment contract with that group, they make you waive your due process rights. And there's nothing protecting you from waiving your rights. So luckily, AAEM's been working on this, and we have a bill on the federal level. It's a bicameral, bipartisan bill. And so we're working on trying to get this passed to fix this loophole that these third-party contractors and these private equity-backed corporate groups are exploiting in order to be able to fire you at will. And I'll tell you a quick story about a friend of mine who was fresh out of residency working in Tampa, and she was the solo coverage ER doctor at night, and it was very busy. They were severely understaffed, and somebody had a stroke in the waiting room. And I'm sure a lot of you can imagine this scenario because of how much boarding there is these days in the emergency department and how many patients have to wait out in the waiting room for long times. But this was even before there was a huge boarding issue at her hospital. This was just, they were severely understaffed. And so she spoke up about this and was fired as a result by her contract management group that rhymes with Envision, or maybe it's just Envision. So she was fired, and she started a wrongful termination suit, which took up like 7 years of her life and eventually had to settle. But I don't want this to happen to other emergency physicians. So that's why we're fighting for this. We don't want you to have to give up your job, get fired because you're speaking up for what's right. We also saw this happen with Ming Lin, Dr. Ming Lin in the Seattle area during the pandemic. He was at the front lines when the pandemic broke in Seattle and was seeing that they did not have enough personal protective equipment. And he spoke up against this and saying, we need more equipment, and was fired as a result. And he's still going through his wrongful termination suit. All right, let's shift gears and we'll talk a little bit about non-compete clauses, because this is something else that employers are using to exploit physicians. We all know that emergency physicians don't have any trade secrets or private patients. We're not taking our drunk homeless man from one hospital to another with us, and I'm sure the hospital wouldn't care if we did. So there's really no reason that an emergency physician should ever have to sign a non-compete. It's really about control, and it's about the corporate groups exerting that control over you so that you can't change jobs easily. And also using that as leverage over the hospital to say, look, my physicians aren't going to leave, they're going to stay. So you should keep me on to staff the emergency department. So these are really golden handcuffs for physicians. It affects all specialties. We've seen where the FTC came out with a rule to ban non-competes, but unfortunately they have chosen not to defend that rule in court when it was challenged. So we're looking at this as this is still an issue that's affecting physicians. Like, you should be able to switch jobs without being told that you can't work in an area for a year, or that you have a certain mileage that you're not allowed to exceed in order to get a new job. Like, people shouldn't have to move out of the area to change jobs. So these are really symptoms of a larger disease, the corporatization of medicine. Whoop, I'm jumping ahead too much. So essentially what's happening is everything is getting consolidated. The system is getting more consolidated, more corporatized. And as a result, the physicians and the patients are suffering. We're eroding the physician-patient relationship. And a lot of this has to do with the way that the laws are written. So there are state laws prohibiting non-physicians from owning a medical practice. And that's what we call the corporate practice of medicine doctrine. When you prohibit a layperson from owning a medical practice, that is a restriction on the corporate practice of medicine. You're saying that a business can't decide how I staff. They can't decide what equipment I'm using. They can't decide my support staff. They can't hire and fire on my behalf. They can't bill and collect in my name without me seeing it. So all those things are important because that affects how you practice medicine. That affects the delivery of your care. So this is important to know, this map. This is taking a look at state by state because this is not a federal issue. They've left this issue to the states, saying that you can decide whether or not you want to regulate the ownership of medical practices. This is very different than other professions. Lawyers can't have outside investment or ownership of their law practices. That's considered unethical. So basically, we've said that people's lives and healthcare is not as important as law, as lawyers and their ethics. So we've basically said we're less ethical than lawyers. And I'm not blaming doctors for this. This has been an erosion over time with businesses and private equity getting involved and things like that, and all this influence affecting laws and lawmakers, that this is how we've ended up. So state by state, if it's a green state on this map, you're seeing that there is no prohibition on the corporate practice of medicine. Green means go. The private equity can roll in and buy up all the medical practices in the area. And the red, yellow, and orange are varying degrees of the prohibition on corporate practice. So luckily in your states, there's some prohibition in Nevada, Arizona, and Colorado, but New Mexico and Utah, it's a free-for-all. So let's talk about what AAEM does against the corporate practice of medicine. Well, we've filed suit against Envision for corporate practice of medicine in California. California, if you remember that map, has strong corporate practice laws. And so we, in December of 2021, sued them for the illegal corporate practice of medicine. They actually took over a physician group at a hospital where we were, AAEM physician group was providing business consulting advice to the physician-owned practice there. And then Envision came in and took over that practice. So when they did this, it was illegal. It was against the law, but the state wasn't enforcing their laws. So we filed suit against them. And what was the result? Envision left the state of California. So they went bankrupt during the course of the suit, which I don't know. I don't think we can claim credit for that one, but maybe. So they went bankrupt during that time, and they actually announced that they were going to leave the state. And at that point, they basically said, look, this case is moot because we're going to leave the state. And so at that point, we said, okay, we're going to settle because we want to protect the physicians and make sure that we can secure a couple things in the settlement to help protect the physicians that were working for Envision in the state. So we made sure that they would not enforce any restricted covenants against the physicians, like the non-competes, so that they could stay working at the jobs they were working at. And also we said that they must uphold any payments for malpractice insurance. So that way we were able to protect the physicians. Now, it wasn't a definitive judgment. We weren't able to set a legal precedent with it, but we still set a precedent that we're willing to fight and go after these big dogs. So we talked about some of these things with our advocacy update. So the Physician and Patient Safety Act is our due process bill that was introduced in May. We talked about non-compete ban. So the FTC came out with this great rule, and then it got challenged in court, and they decided they're not going to defend it. But almost at the same time they announced they're not going to defend the non-compete ban, they said, we want to set out this request for information to specifically look at healthcare. They called out healthcare, saying that there's a problem here, and maybe we need to look at non-compete specifically in healthcare. So we submitted comments to that. We're going to meet with them again. So we're hoping that this means that they'll look at healthcare as a special situation and help uphold banning non-competes in that situation. And there's also a bill in the Senate that would ban non-competes, the Workforce Mobility Act. So we're advocating for that. And we've seen some good movement on corporate practice medicine at a state level. Some states are trying to strengthen their laws and close the loopholes that businesses have exploited to have corporate practice medicine illegally in their states. So Oregon just passed a very good corporate practice bill that got signed into law. And then California and Massachusetts have passed legislation in the last year that specifically require more scrutiny of healthcare transactions to prevent these private equity mergers and takeovers and this over consolidation that's happening that can threaten healthcare systems. And then we've talked about how the states aren't always enforcing their laws or don't have adequate laws or have no laws. So we have to look at this at a federal level. So we really have to look at federal legislation to prohibit the corporate practice of medicine so that doctors can be back in charge and they can balance their Hippocratic oath with the business interests of running a healthcare business. So why are we talking about all these different advocacy priorities and what is going on in emergency medicine? Well, emergency medicine is really at an inflection point. We've seen that policy that is happening at a state and federal level is really reshaping how we practice. And so this is a defining moment. we're sitting at an intersection of policy, public trust, and systemic failures. So let's look a little bit at our political landscape for the last year. We've seen a lot of activity, a lot of aggressive executive action with executive orders. And it's interesting because a lot of these orders, they're not coming through congressional approval mechanisms. They're not actually being written into law, but yet they're being followed. So it's really an interesting time to see how much things change based on executive power. And then at the same time, we're seeing our institutions, federal institutions, being completely restructured and their role changing in terms of how we're administering public health. So specifically looking at HHS, we've seen that there's been a new philosophy with the leadership where we're being a little bit more liberal with our messaging, shifting away from consensus science. And I'm trying to say this as apolitically as possible, because the point is that we have to look at the policy and not the people, because the policy is what is affecting what we're doing. So that's really when we start distrusting institutions like the CDC, shifting away from consensus science, that's when we're really at a critical point in our ability to administer care. So science is really under pressure right now. We're seeing that advisory bodies are being weakened. A lot of guidance is being politicized, and that's making it really hard when you're trying to advise patients, because sometimes it seems like you're taking a political viewpoint when you're just trying to tell them the facts. And states are stepping in to fill this vacuum of federal guidance, and sometimes not in good ways. Like in my own state of Florida, they're taking away any kind of vaccine requirements. Things like that are going to affect how we care for patients in the emergency department. We're seeing increased vaccine hesitancy, more patient refusals. We're seeing that people are turning more to social media and influencers in order to get advice. And there's just been this declining trust in physicians ever since the pandemic. And we're seeing that as a result of policy changes and funding changes, that research and innovation are being put at risk. So there's threats to the NIH and CDC funding, cuts to indirect costs, and all this is going to translate to slower advances in care. So how does this relate back to emergency medicine? These policy decisions are going to lead to more crowding in the emergency department, more outbreaks. We're not going to be as prepared. And with less prevention and higher surges, it's going to lead to more moral injury and burnout for emergency physicians. So here's our moment where we can step up and lead the change that we need right now. Physicians still are the most trusted voices in healthcare. Even though we see that the overall trust in physicians has declined, we're still the most trusted voices. So we're seeing all the consequences of these policy changes first. So we really have to speak up, and we have to speak clearly and with data, and try not to politicize things. We need to link policy failures to what's happening in our emergency department, like crowding, boarding, burnout of emergency physicians. So part of that is we have to unite, and we can do that through AAEM or through other avenues in organized medicine. So now that I've completely trashed our current mood and we are the dumpster on fire, let's talk a little bit about how we can make emergency medicine more sustainable. So I think that policy stress is compounding our existing pressures. We have roughly 140 million annual visits to the emergency department, and that's projected to grow 4% over the next 10 years. We're seeing a highly aging population with higher acuity, and all these systemic pressures are threatening us, between workforce issues, decreased compensation, and operational issues. We're really at this inflection point that I keep talking about. So let's talk about workforce. I know that a lot of people are still thinking back to 2020 when the big study was released, the workforce study that projected a surplus of emergency physicians by 2030. It may have been misleading. I think that the pandemic really accelerated our attrition rate, career spans have really dropped from 30 years to under 20 years. So we're seeing a lot of mid-career physicians leaving. 50% of emergency physicians have considered leaving the field by the age of 45. I think I'm at retirement age now. So it's not sustainable. We can't keep losing mentors and losing our mid and later career physicians. So we need to, the signs that the system is collapsing is when you see the mass exodus. So this is our early warning sign. We gotta stand up and do something. So we've seen also a residency expansion at the same time, which is maybe a corporate kind of push versus just demand for more physicians, but quantity without quality is going to worsen our long-term sustainability in emergency medicine. So if growth is outpacing true demand, that's a problem. And there's also, we're seeing a large variation in training quality, unfortunately. 30% of programs are below critical care benchmarks. That's a big problem in training. Under-resourced programs can sometimes lack the volume of patients that physicians in training need in order to get experience, and you can lack mentors, lack of mentorship. So we might be seeing a two-tiered workforce emerging. So training quality directly connects to patient safety and workforce durability. Unfortunately, the ABEM qualifying exam pass rates fell to 84% in 2024. So normally the historic norms for pass rates are around 90 to 95%. So unfortunately, we did see a little bit of a drop in pass rates with CMG affiliated programs on average, not trying to call out any specific programs. And non-CMG programs, their average pass rates were around 92% when you look at all the data. So these training gaps are going to eventually threaten patient safety. We've also been seeing gaps in unfilled positions with the match, but this rebounded in 2025. So that's a good sign. But now is emergency medicine not as competitive as it used to be? So we have to look at these issues, because if our applicant pool has changed, that's going to affect training as well. Let's look at our compensation. So this is not about greed. I know everybody's like thinking about their paycheck, and it's not about greed. This is about sustainability too. If you want people to stay in the field, the compensation has to be there. And we've really stagnated. Even though emergency physicians drive about 50% of hospital admissions, and emergency departments are the major profit centers for a lot of hospitals, the hospitals are collecting all these facility fees that are well above and beyond what the professional fees are. And so you're only getting these much smaller professional fees. And then any downstream revenue that you're producing for the hospital is not being shared. So you're doing all these stroke protocols and sepsis protocols and everything. Those make big money for the hospital, but they're not sharing that revenue with you. This is scary. The non-physician practitioners are being substituted for physicians more and more. So physician-only visits in the emergency department are down to only 62%. So only 62% of emergency department visits nationally are by a physician only. So we're seeing the replacement happening. We're also seeing that with drop in the conversion factor for Medicare. So this is part of how you get paid, right? Medicare determines what the conversion factor for payment is every year. And every year they've been dropping it. There's supposed to be a congressional fix this year, but it still didn't get us whole. And we have no payments from Medicare that are tied to inflation rates. So even though we maybe are going to get back some money this year to at least not be dropping, we are still going to be looking at overall decrease in pay this year because of inflation. And Medicare rates determine payment for all insurance. So your insurance contracts with how you get paid are determined based on a percentage of Medicare. So if Medicare goes down, all your payments go down. And this is a big problem. We're seeing that vertical integration, where hospitals, insurers are buying up physician practices or employing physicians, that they're cutting our compensation more. 40% of emergency physicians are now salaried. So we used to have a lot more independent physician groups in emergency medicine, and that has definitely waned. So all these policies that I'm talking about with conversion factors and things like that, that directly cuts into your pay. And then when we see other things like No Surprises Act delays, there is an independent resolution process, but it can sometimes take 3 months. So if you don't agree with what you're being paid by the insurer, and because of the No Surprises Act, you can't send a surprise bill to the patient to cover the insurance deficit. If you want to dispute the claim, it can sometimes take more than 3 months to get the money. And payers have an 18% claim denial rate. So you try to submit a claim to get paid, 18% of the time it gets denied. And then most of the contracts with insurers that physician groups have, or even contract management groups have, are 10 to 15% below market contracts. So you're being underpaid from every end. So let's look a little bit at the systemic problems. Boarding is probably one of the biggest systemic problems we're seeing in real time. This is where like everything converges. So 85% of emergency departments are typically affected by boarding. 40% of boarding patients board for over 4 hours. 6% board for over 24 hours. And I'm sure our rural colleagues can talk about this too, because of them not being able to transfer patients out. It's the same issue. For boarded patients, mortality increases up to 25%. So if they're sitting in the emergency department for more than 4 hours, their mortality is going up. Infection rates go up. The safety net hospitals are being hit the hardest. And this is, I think, a huge driver of our burnout. I think the Mayo data from 2025 shows emergency medicine is number one again, 65% burnout rate. I don't really want to be number one at that. I think we can do better. And we talked a little bit about this, how a lot of the metrics and like stroke alerts and things like that that we do in the emergency department are directly tied to revenue for the hospital. So there's this like misalignment between the work we're doing and the payment the hospital gets. And we're not seeing any kind of benefit of doing it, but we're just like being thrust into more and more protocols. Just for example, like a stroke DRG jumps from $8,000 of reimbursement for facility fees to $14,000 the minute you activate a stroke alert. So their reimbursement almost doubles the minute you do that. Trauma activations, huge facility fees, but not physician fees, right? And then you're blamed every time you have a fallout. So there's no shared upside, and you get all the downsides of having to implement lots more protocols and metrics. So what can we do? There's some things that we can prioritize to help with all these different issues. We talked about workforce, compensation, and operations. So in the workforce, if we can standardize residency quality, which I know the ACGME recommendations to change the residency program length of time, training time, as well as to implement a lot more rotations and everything has been very controversial, but this is something that might actually help standardize quality. I don't know if a lot of people realize 10 years ago, they dropped the standards a little bit. I feel like this is just like a readjustment for the massive expansion that we're seeing. And whether or not they settle on 3 or 4 years or any specific time frame, I think we need to look at this as like improving our training. And there's another thing is we can stabilize like the applicant pipeline by amplifying emergency medicine's allure, like maybe launching some national campaigns, highlighting the positive aspects of emergency medicine. I think the show The Pit on HBO, if you haven't seen it, I think the second season is premiering tomorrow. I think that show in and of itself is a great thing to amplify emergency medicine. Things like that can definitely help. I think that in terms of compensation, we have to tie the Medicare conversion factor to inflation, which is something that AAEM has been partnering with the AMA on and writing letters and trying to talk to legislators about that. We need to reform the timelines for the independent dispute resolution for No Surprises Act, because waiting 30 days to dispute a claim and it's just delaying payments more and more. It's affecting our compensation. And educating emergency physicians about these issues. I'm giving you just a tiny piece of the pie, and you guys really need to know all this stuff in order to better understand where your money's coming from. And as far as operations, we can help reduce boarding through having these zero delay coalitions. Hospitals can use things like AI bed predictors, which, like, again, how can we use AI to actually improve what we're doing? Use AI bed predictors. And that way you can allocate beds properly for like your post-procedural patients versus your emergency patients, and having discharge hubs and things like that. There's ways to move patients through the hospital more efficiently and to plan things out more efficiently, that if we can really get on board with things like that, we can reduce boarding. And then as far as like these CMS kind of metrics, like the bundles for sepsis, stroke, trauma, all those things, if we really can shift to more risk tiered mandates, instead of just saying, oh, you fell out, you don't get paid, or you hit all your points, so you get paid, really making it more individualized and based on true rewarding of outcomes over adherence is really going to help us deliver better care. And then in terms of physician groups and non-physician owned groups, like really having transparency for what's billed and collected in your name. For physician owned groups, like having transparency about governance and like, what are the partners making? What does the money get spent on? And all the physicians having open books and access to open books is really important for longevity in the field. So you're not feeling taken advantage of and burnt out because somebody else is profiting off your back. So why are we talking about all this? You're probably like, this is not an emergency medicine talk, but it really is, because now more than ever, all this advocacy stuff is as important as patient care. Because if we don't stand up and talk about this, policy is going to shape how we're staffed, how we're paid, how safe it is to practice in our work environments. So being silent is allowing more harm to occur. So we have to engage. So pulling it all together, politics is really driving a lot of what's happening with our workforce instability, our eroding of compensation, and systemic failures. So we have to get engaged. We have to support professional societies like AAEM so that we can defend our patients and defend science. So I'm going to shift a little bit and now talk about our states. And I wanted to put this slide up because I feel like I became much more involved in health policy and advocacy because of this same situation of being chased by a bear. Because when you get out in the field and you're working in community medicine and you're just seeing like all these things affect your day-to-day practice, and it can be frustrating. So I wanted to get out there and actually talk to the people that can influence how the laws are written and affect policy changes, because I was seeing it's tough working out there when other people are making decisions for you. So you have to have a seat at the table. So let's talk about our Four Corners Plus states. I'm just going to highlight scope of practice for a minute for the residents and students who don't really understand what this is. So everybody has a certain level of training and education. And specifically physicians in emergency medicine have 7 years of medical school and residency. As you have to take your 3 USMLE step exams. You have to graduate from a residency program. You have to take your board examination. Non-physician practitioners don't have anywhere near these requirements. A lot of them are only trained for 2 years in school. A lot of them go to online only schools and work full-time jobs while they're in school. I don't know how many of you had a full-time job when you were in medical school. I'm sure almost none of you. And these are like schools that are like 100% acceptance rates sometimes. There's really a different level of education and training that's happening. And when we try to give people a scope of practice outside of what their training is, that's when we can see patients being harmed. So unfortunately, in most of your states, you have lost this fight. Nurse practitioners have full practice authority in all 5 states. And I think it's only Nevada where physician assistants are still under a supervision model. So in all the other states, Arizona, New Mexico, Utah, and Colorado, physician assistants are under what's called a collaboration agreement, which really means that their scope of practice is determined more at the practice level, and they have some kind of like collaborative like piece of paper that says what they can and can't do. But it's still, it's in essence, it's independence. So let's look at this. Arizona, you have a split legislature. So you have a Democratic governor with a Republican legislature. That can make getting policy passed at a state level difficult at times because your governor may veto anything that gets passed by the legislature. The good news with Arizona, you have whistleblower protections, like some form of due process. If you're calling out something related to patient safety or fraud, and you do have corporate practice medicine prohibition. Non-competes in your state are enforceable, but only if they're reasonable, and you have no tort reform whatsoever. There are no caps on damages. Nevada, you again have a split legislature, but with a Republican governor and a Democratic legislature. You also have healthcare worker whistleblower protections. And like I mentioned before, you're the only state that still has PAs supervised, and physicians can supervise up to 3 PAs under one physician. And I think this was just expanded last year. So I'm not sure if that changed for emergency medicine, but just be aware that if you're working at a hospital and they're staffing you single coverage with 4 PAs, that's maybe against the law. You have corporate practice of medicine prohibition. Non-competes are enforceable if reasonable. And the sad thing is there was a bill that was passed by the legislature in 2025 to ban non-competes that was vetoed by the governor. So again, good policy that was because the legislature is divided between the executive and the House and Senate that you weren't able to get that through. There is a cap on non-economic damages, so you have some tort reform, so that's good. New Mexico, you have a fully Democratic government, so there's no infighting, hopefully. What's interesting with New Mexico is you have one of the oldest physician workforces in the country. So I think that when this wave of older physicians retires, you're going to see major physician shortages in your state. So you have to keep a lookout for that. So that's something like, the reason I'm talking about all these different issues, these are ways that you can change policy on a state level to affect how your workplace is, right? And so this is something that when you're talking to legislators in New Mexico, you might want to bring up like, hey, we're going to have a major problem here we need to recruit more physicians to our state. So maybe you need to ban non-competes in the state, because then more physicians can work here and not have to leave when they change jobs because of a non-compete. Or maybe we need corporate practice of medicine prohibition in New Mexico to attract more physicians to the state. So there's ways of looking at issues in the state to be able to exert policy changes with legislators. And Utah, so you've got the Republican trifecta. Corporate practice of medicine is not prohibited in your state. And you do have tort reform and restrictions on non-competes. So you do have some good stuff going for you. Colorado, you have a Democratic trifecta. The problem with Colorado, as you heard earlier, is that it's a competitive job market. There's relatively low compensation for emergency physicians. And you do have some form of tort reform, but the caps are 1.5 million, which is, I guess you could argue maybe that's the good, but that's very high. And then they just passed a bill saying that non-competes are void for most physicians in the state of Colorado. So that's good. All right. So let's talk about how you can make a difference at a state level. AAEM is not large enough to be able to put boots on the ground in all 50 states in terms of getting to the legislature and lobbying and all that stuff. So the way that you can exert influence in your state is join your county medical society, get involved, be a delegate to your state meeting, join committees, run for the board, take leadership roles and stuff. And you can exert policy changes in the county medical society, and that'll translate to the state medical society, which can then benefit emergency medicine, benefit our ability to take care of patients. If you're a student or a resident, you can ask to be a student or resident representative on your county medical society board. They're always looking for people. Half the time, if you just show up and say, I'm interested, you'll be on the board. And that's a great way to not only get experience in organized medicine, but also to be able to talk about our issues and have a seat at the table. And then this translates to get involved in your state medical society, join and attend their annual meeting. Most state medical societies will have an annual meeting where they talk about policy. And if you can bring resolutions, participate in committees, you can change their policy. And I'll talk a little bit about resolutions. I put PACs up here just to say that we all need to start donating to our state medical society PAC, to the AAEM PAC, in order for these organizations to have influence with legislators. We need PAC money because that's just how the system is built. And physicians are notorious for not donating. I need everybody that's listening to make it a priority to donate something to your either AAEM PAC or your state medical society PAC. So this is just like some examples of, in the state of Florida, the Florida chapter of AAEM passed all these different resolutions that changed policy in the state medical society. So the Florida Medical Association had no corporate practice of medicine policy. They had no policy on billing transparency, saying that physicians should see what's billed and collected in their name. They had no policies about that every emergency department should be staffed 24/7 with a physician. So all of these things have been passed in the state medical society to change their policy so that when they are lobbying and going to talk to the state legislature, they can actually be advocating for our policy and our position. So just an example, in Florida, we had a resolution talking about graduate assistant physicians, and it actually turned into law. So this is an example of like how you can do something like this. So we wrote a resolution, myself and another emergency physician, Megan Kaur, where we said that medical school graduates from US medical schools, that if they are unable to match, that they can work under a licensed physician for a limited amount of time. I think we said 2 years or something like that, while they try to match again, and basically work under the scope of almost like a physician assistant, but be able to work in medicine, be paid, and still be able to try to match again. So this was something that the legislature really liked as like a solution to the physician workforce shortage, saying if we can get some of these unmatched graduates to stay in the state and work while they're trying to rematch, that's going to help increase access to care. So this is a statute where we created this limited license called the Graduate Assistant Physician License in Florida. So the last little bit I'll say is there's stuff that if you don't have time to join your county medical society, state medical society, join AAEM as like an active member of committees and things like that, you can still do other things. You can just pay attention. Look at what laws are being introduced. Look at, like, read your state medical society's legislative update. Like, just pay attention to what's going on around you. Read news articles. Educate your colleagues, family, and friends. Talk about these things with them. Just go meet your legislators. I can't tell you how often it is that I go into the Capitol in Florida, in Tallahassee, and I talk to legislators, and they're like, you're like the only doctor that comes and talks to us. So if we're not going there and talking to them, how are they making decisions on health policy? Like, the wrong people are there talking to them, right? So email them, give your opinion, go to fundraisers for candidates. That's a huge way to show support for candidates. And then they're going to be listening to you in the future if you're showing them support. And then you can run for office. My husband actually did that in 2020, which was like the worst year possible to run with a global pandemic and the craziness of that election year. But he ran for state senate, and unfortunately he lost, but it was a great learning experience for both of us. And there's different groups that will support physician candidates for office. There's a specific group called 314action.org, where they are specifically supporting science, like pro-science candidates. And then the AMA has AMPAC's candidate workshop and campaign school. So there's ways to get training on how to be a candidate, how to run a campaign. And there's ways to get support for this. So if you're interested in it, you should definitely look into these different avenues. So I'm sure a lot of you are thinking, and I had to take out my surfing picture because I don't think you guys surf out there, do you? So I put in a hiking in the desert picture. But I'm sure a lot of you are saying that just sounds like a lot of work. Like when I'm not at work, I just want to decompress. I want to go out in nature. I want to be alone. And I agree. I was like you. I was like, I'm going to go scuba diving and go traveling. And my life definitely looks very different now. I spend a lot of time at meetings and talking to people and just making connections and networking and talking about health policy. And so, yes, life can look a lot different when you start getting involved in these things, but both are very good. So if you can't give your time like I'm doing, then just join, give your money. That's what I have to say is if you can't give your time, at least join and be a part of it. And your membership dollars help and make a big difference. So this is my plug for Scientific Assembly that's coming up April 11th to 15th in Seattle, Washington. I hope to see everybody there. Really excited for that. And if you're interested in all this health policy stuff I've been talking about, we have our Emergency Medicine Advocacy Education Summit coming up in June. And then we'll spend the next day on the Hill meeting with legislators, and we'll basically set up a schedule for you if you come to meet with your legislators. And one last thing I want to say is I'm going to make sure the QR code is visible there. The AAEM Foundation. So this is where AAEM is unique among other professional organizations. We actually have a legal fund to help physicians that have been terminated without due process, to help enforce the corporate practice of medicine. This was the fund that we used to help fund the lawsuit against Envision. So, and if you have a personal issue where you get fired for speaking up for patient safety and you need to hire a lawyer and things like that, this is who you contact to help get you funding. And that's something that no other professional society really does for their members. And that's what really makes AAM unique. So thank you very much. This is my contact info and this is my zoo. And I hope you all got a lot out of that. I know it was very long, but chock full of important information. So thank you.
Thank you, Dr. Norton. We are obviously so impressed with the presentation, and I'm happy to kind of learn all about what you do and what AAM does and how at times it definitely felt bleak in part of that presentation in terms of where we're going and what we can do as emergency medicine docs. But hopefully everybody will take solace knowing that there are people out there that are working to making this better for all of us. So thank you. Let's finish this up with one last mini presentation. Then you'll vote on some speaker awards, and then we are going to hand out some raffle prizes for the residents who have hung on to this call here. So let's move on. We are going to bring on Dr. Katie Wisniewski. She's going to be giving some closing remarks. She's the president of AAEM RSA and a current resident with the John Peter Smith Health Network in Fort Worth.
Hey y'all, I am so excited to be joining you, and honestly it's a good kind of tack on to Dr. Norton's amazing lecture talking about AAM. If I can share my screen, hopefully we'll be slightly more uplifting and motivating and talking about how residents can get involved specifically with AAM RSA and just sharing a little bit about our organization. All right, do we see that? Does that look?
Looks good.
Finest, great. And I just want to give a big shout out. Obviously, Dr. Norton, thank you so much for giving the keynote speech. It was really wonderful. And Dr. Warr, you put so much effort into this day. And thank everyone for being here until the end. I will be super quick, and then we have prizes. And so hopefully that'll be really fun and a great way to end the day. And if you have things like shift and going to a department that is really boarded up like mine is, hopefully this will make you feel a little bit better. So I'm just going to talk very briefly about AAM RSA in particular. Dr. Norton honestly hit a lot of the high notes in terms of my background as well that I usually give a whole spiel about where we are and where we've come from in emergency medicine, how AAM was created. So I'm just going to run through this super quickly and just say Even though it seems like there are a lot of changes to our specialty, and especially where we are in the House of Medicine, just know that emergency medicine is a relatively new specialty, and I would say we are still trying to find our feet. And I know the change of, is it going to be 3 or 4 years, and the change of board examinations and all that seems really daunting. I think ultimately it will just enhance our specialty, and it's a really unique time to be in emergency medicine. I hope you come away with some positivity, and the job market should be very exciting to enter at this time frame, and hopefully you take it as an exciting challenge. I won't go too much into the long history of AAEM. This was the book that Dr. Norton mentioned that kind of kicked off what our organization is really all about. RSA in particular actually was founded a little bit later. It was founded in 1999 as a section. If you have been involved in AAEM, you know that there are lots of different sections in terms of what I like to call the big parent organization. And then we formed and became our own organization, independent, in 2005. And so we are so lucky to be able to do really anything we want to in terms of that. So really focused on resident and student advocacy, education, and getting y'all involved on the national level. Here's our vision statement. Again, we're the advocacy organization, really wanting to teach residents about advocacy, how we can get involved on various platforms. And our values, you can read these for yourself. Mission statement, really emphasizing current and future training and practice environments. I think we are really lucky, especially with AAEM RSA, to be very involved with other organizations, collaborating. It has been my mission as president to be much more collaborative with the other national organizations, such as SAAM, ACOEP, EMRA, ABEM. So it's just really awesome to be able to do that and to advocate for you as residents as well and our training platforms. So let's dig in a little bit to benefits, and this will be my ploy. If you are not an AAEM RSA member, you absolutely should join, because one, our pricing is the most competitive, I would say, on the market for what we offer you as benefits as well. So many free benefits and a lot of discounts. I know your residency programs might already provide you some of these, but if they don't, definitely really interesting to get things like MRAP. I use MRAP all the time, especially on shift, EKG weekly, ITE prep, all of these things, super helpful. The laceration course, I've gone to a few of their Zoom lectures, and you think about something that seems so bland, especially as a upper level resident, but you're really learning nitty gritty and advanced techniques on complex lacerations, which is something you absolutely will be doing in practice. Podcasts, journals, magazines, and these are not only things that you can access as medical students and residents, but they are also things that you can contribute to. So if you have an idea for a learning opportunity, an interesting case, you absolutely can, you can always reach out to me or our administrators and see how you can connect it and share your wisdom with the broader population. We are always looking for more resident involvement, especially in our online platforms, in our newsletters, and our journals as well. So these, I think, are really interesting that we have been capitalizing and making brand new kind of handheld and electronic copies of different guides. So if you are AAEM RSA members, you probably already have the ultrasound guide. And this is great for your intern level, especially if you haven't done a lot of ultrasound prior to residency. Super helpful. We hopefully will be coming out with more of an advanced guide if you are interested in ultrasound fellowship or for more of our senior residents. So that should be coming out in the next few months or later this year. The ED Scut Sheet, again, very helpful for interns, or if you know any rotating medical students, this is really great to organize all of your thoughts. And that's available on our online library, as well as our critical care pocket guide and our notepad as well. I'll talk a little bit more. We have a whole critical care course that you actually can still sign up for, but the pocket guide goes along with that, but it is also a great standalone. If you haven't done your ICU rotations or you need a refresher, it has so many things from introduction to vasopressors, dosing, ECMO considerations, your halo procedures, all in this super helpful pocket guide that you can just put in your scrubs and bring to work. And if you're interested in a group discount, just reach out and we can get you these pocket guides for your entire residency program if you're interested. Lots of CME online. Here are some upcoming events. Dr. Norton already highlighted our scientific assembly, but a few others. If you are a medical student on here, congratulations, you are way ahead of the curve. We have medical student symposia. A lot of you here are probably residents. Not super relevant, but we still have this year for kind of looking forward to the next cycle for international medical graduates, Western and Northeast, and these are all virtual. So if any medical students are interested, they can sign up. And then here is what I was talking about, our Introduction to Critical Care course. So you can sign up. Sign up is open until January 28th. You can find that on our website, our AAEM RSA website. And it is a combination of Zoom virtual lectures that you can either watch live or recorded. And then it culminates with a final course that's actually at our scientific assembly. It's before the scientific assembly kicks off, usually the day or two before. So you can use all of those skills that you've been learning about on the course, and you can do it in person, including ultrasound, again, halo procedures, things like central line, cannulation, all of those types of things. I took it as a medical student, really helpful for M4s and interns. It talks everything you need to know about critical care and more. We don't have ECMO at our shop, and the more I get to learn about ECMO, the more knowledgeable you are if you potentially are at a shop that does it in the future. And then scientific assembly, we have specific medical student and resident tracks. So really recommend that you go to scientific assembly. Again, pricing is very competitive. I believe that you can sign up for scientific assembly and then you actually get essentially refunded the registration cost when you go. And I know a lot of your programs already sponsor one of your classes to go. So congratulations if that is one of your programs. And then Dr. Norton briefly mentioned this as well. We have health policy days, specifically where we go to DC and you can talk to your own legislators. And we have an amazing advocacy group that gives you basically a whole primer on what the current issues are that AAEM is focused on, how you can talk to legislators. And so again, it's really as simple as showing up and being eager to learn. It's 1 or 2 days in June. So if you're interested, put it on your calendar. It was an invaluable experience for me this past year and just an awesome learning opportunity. So highly recommend you get involved. Our board of directors, unfortunately, it closed for nominations, but highly recommend you vote for these awesome people that will be on the board next year. Voting is open until I believe the end of the month, and then same thing for our medical student council. Cabinet of delegates is something that you could potentially get involved with if your program does not have one already. So similar to SAM, EMRA has a very similar kind of process where you have one representative from your program and one representative from every medical school. So if you're not sure if your program has one, you can always email me and I'll double check, and we have different projects and things to stay involved with AAEM RSA that way. Lots of different work groups that are project based, again, to hopefully produce something that you can put on your resume and say, hey, I really produced for AAEM RSA in this one particular way that is helpful to both of us. And then I don't think there are a ton of medical students, but we have ambassadors at our scientific assembly. So here are ways to follow us, be engaged. I will put my email in the chat if you have any questions. And I will stop sharing my screen and then we can move forward.
Sweet. So you will see now a poll here that is, if you look down under screen, we made live one of the webinar polls here. there's going to be 3 questions. We are going to be voting on kind of 3 different awards. It's going to be which speaker delivered the strongest overall presentation. So that's like clarity, engagement, and educational value. Which talk topic was the most compelling, relevant, or well chosen for emergency medicine practice? And then ultimately, most practice-changing topic, which is which presentation is most likely to change how you practice or think in your next shift. If you can spread the wealth and not vote for the same person every time, probably be great. I'll just put that like unbiased plug in there. And while we are voting and doing this, we're going to have Dr. Wisniewski go through the resident raffle, and then when she's done giving out those awards, we'll talk about our speakers. And while she's pulling it up, there was a couple questions in the chat. In terms of accessing today's recording, I'll talk to kind of the AAEM staff and see about how we can get that out to you guys and in what capacity. And we'll go from there. I'll also follow up with everybody that some of the speakers have sent either slide handouts or their PowerPoint slides to me for distribution. I'll send a summary out to everybody too, if you guys just as needed, if you would like to review the information from today. Ready, Katie?
I'm ready. I am random numbering people, but presuming that you are here. So give me like 30 seconds to run the list of who's here. Okay, so our first winner. Oh, someone did residency at JPS. I will say hi to Huggins for you. Okay, our first winner is Dr. Scott Austin out of Creighton. Congratulations. Okay, don't mind me. Let's respin. I need some like a background game show music here. Okay. Our next winner, number 23, Sarah Golden from COPA. Congratulations. You are our second winner. Let's respin this fancy computer wheel. 46. Okay. Yep, you're here. I wish I had a quicker way to do this. I apologize. Okay, our third winner is Dr. Mackenzie Spencer. Okay, we have 2 more. I'm on the edge of my seat to see who the big winners. Also, if any of you are not residents, just let me know and I can respin. Some of you haven't registered. And this has caused a problem because some of you who are on here haven't registered and aren't on my sheet. That's okay because you are here and we will still award you. Dr. Haley Furman is my next winner. I assume you are a resident. You can let yourself be known if you're not. And then I believe we have one more big winner. Whoops, sorry, muted. Our last winner is Dr. Hannah Sivak from Cueva. That should be 5 who are all here. Thank you so much for being here. This was fun. I hope, Dr. Warr, you actually got these names because I actually wasn't tracking. Can you just message me if I announced your name? I had 3 different things going on to manifest this. So message either of us.
Yeah, you can message me if that was you. I wrote everybody down, but we can confirm as we go here. So we're finishing up here with the Educational Day Speaker Awards. So these lucky winners are going to go home with a $50 Visa card sent via email from AAEM sometime after this event. So for most practice-changing talk, we have Dr. Tarzia talking about steroids in the emergency department. Congratulations to Dr. Tarzia. I wish I had, I need like sound effects, unfortunately. For best topic, we have Dr. Domansky, gas station pharmacy, as everyone is along for the ride on that journey with her. All right. And then for best overall speaker, we have Dr. Wolf talking about PERC and PE with her logical algorithm and her approach to evaluating patients with the years criteria. So there we are. That is our poll and quizzes for today. So congratulations, everybody. And like everybody who's still here, thank you for being here. I hope that this was like a good experience for all of you. We have just, if you haven't filled out the interest form, throw your name on the list. Just a quick second for this QR code. And then anybody, like just feedback in general, hopefully this is something that we're going to be doing moving forward yearly as we get this chapter off the ground. If you would prefer different format, different time, different things, if you have anything you really want to comment about this event, please give us a scan and we'll look into adapting this to make this better for the future and hopefully have progressively more involvement with all of the wonderful people here that make this special. And thank you again for the speakers who dedicated their time today. We really appreciate it. So thank you. All right.
Thank you for putting this on. This is great. It's a very big undertaking. I think it went very smoothly for the first year. So I think it's very impressive. Good job, Dr. Warr.
Thank you. All right. Let us close this out. I will send all the information your way regarding like any information that we get and the awards. So congratulations, everybody.
Thank you, Dillon. Thanks for everything.